So I'll just give them a quick date to get back to them when we've had a workshop. Sorry,
They'll do that until all their children see you.
The response I would say is just pleased to see a festival. You know what I mean? It's,
Bwrdd croeso pawb. Welcome everyone to today's board meeting. Thank you for attending. Hefyd croeso pobl ar line yn edrych y cyfarfod heddiw. Also to people who are online watching the meeting today and anybody else who joins us during the course of the morning or the afternoon. It's great to see everybody. You'll no doubt realise we've got quite a hefty number of papers to work through today. So important we pace ourselves as we go through them, recognising that some of those papers that we need to give most attention to will fall during the middle part of today's proceedings. Before we begin, just a few questions and thoughts from me. Did everybody receive the papers in good time? Great. Are the papers clear and comprehensive? Seeing lots of nods, I'm presuming yes. Is there anything members feel has been omitted from the paper or the agenda that they would like to add or discuss? No? Great, okay. And then my other remark before we kick off is, I've said it before and I'll continue to say it at the start of each board meeting, is that in order to ensure that we are consistent in the way in which we make our decisions, that we just apply a set of design principles. Those design principles focus upon ensuring our decisions are fair, they are affordable and sustainable, they are consistent with our strategic approach and what we're trying to deliver. They don't create an unhelpful precedent. So on the basis of having made one decision, we then have to make another decision that corresponds with that, even if it's right or wrong. And finally, they're safe. So we put patient safety and quality at the heart of our decision making as well. Is everybody clear about that? Great, okay. So just some further thoughts before we begin the agenda. I'd like to welcome Sarah Haraway, who has joined us as a new independent board member community. Great that you've joined us, and welcome, Sarah. Also, this is Sharon Daniels' first meeting as the permanent and appointed Executive Director of Nursing. Thank you. Fantastic you've joined us, Sharon. Great. And also, this is Mark Henwood's first meeting as the newly appointed Medical Director for Hull, our University Health Board. Great you've joined us. Clearly, they've been here before. Clearly, they've been talking before at this meeting, but now they have different status. We don't expect you to say anything different from what you were saying before. Great. We have a number of items during the day when people will join us, principally around the clinical services plan. Well, Senthil Kumar and Irie Edmonds will join us for the basis of that conversation. Brilliant. Okay, so any apologies?
Chair, no apologies today, Chair.
Great. Okay. Declarations of interest? No? Can we?
No.
Eleanor.
Just one, Chair. I was appointed as the Wales member for the Professional Standards Authority on the 1st of May. It's not a conflict, but best to note it.
Great, okay. If we could do that, that would be very helpful. Thank you, Eleanor. And I'm glad you're better, even if you don't sound it.
Thank you. I feel fine, thank you, Chair.
Great, okay. If we could move to preliminary matters and the minutes of the public meeting held on the 27th of March, can we approve them as a record, as a true record? Any points or questions that individuals would like to raise? If everybody's comfortable with them, then we'll agree the minutes. Thank you, Claire. Very good set of minutes. Let's move to matters arising. So we have a number of items which I think we've kind of been working through. A number of completed items. I'm just seeing if there's anything outstanding or anything we need to pick up.
Yes, Chair, there is one outstanding on PM 2551 in relation to the transitional MOU between ourselves and Swansea Bay Health Board, which hasn't yet been finalised because we're just working through some information governance issues and just working for the lead for the MOU to come back into work, and then ourselves and my colleague in Swansea from a governance perspective will ensure that that's transacted through with Andrew Clibbers as the lead executive chair.
Great, okay. Thank you very much. Colleagues, any further points anybody would want to raise? There are a number of items which will come up in the course of today's meeting, so where we've referred to papers, they'll be carried through this morning. I don't think there's anything else. Great, okay. Can we also approve the minutes of the corporate trustee meeting held on the 27th of March? Right, I'm seeing nods around the table. Let's approve the minutes of the corporate trustee meeting held on the 27th of March. And then if we move to item number 6, report of the chair. This is my regular report in terms of what we've covered since we last met as a board. I'm not going to go through this in any detail. I'm presuming that you've read this and understood the detail. The point I would raise under my objectives for 25-26, we've suggested these have now been confirmed. They haven't quite been confirmed, to my knowledge anyway, on the basis that we have received the broad kind of detail of the objectives from Welsh Government, and I've been busy populating those objectives with what I think are the core activities I need to be responsible for over the course of the next year. Those activities are just about, the statement of my objectives is just about complete. And what I will do is then meet with each of my IMs to make sure that that's translated into your responsibilities as board members as well over the course of the next month. But that's all progressing as one would wish. Any other points that people would like to raise?
Chair, Lisa's got a hand up.
Please, Lisa.
Thank you. Could I just advise as well, in terms of the values which have been refreshed, the OD team are now starting to look to engage with our workforce around how we've come up with the 3 words and also the behavioural framework that will sit within our values.
Very good. And to note, Michael Gray has been reappointed as Social Services Representative for a period of 1 year. Welcome, Michael. Thank you. Okay, I'm not gonna labour my my paper. Let's move on.
Are you okay with the recommendations? Yeah.
Recommendations. So support the work engaged in by the chair since the previous meeting, and the role and the note of the topical areas of interest. I'm presuming we do, and endorse the draft new approach to volunteering in Wales framework Appendix 1.
Thank you.
Great. Okay. Thank you. Let's move to item 7, report of the Chief Executive.
Thank you, Chair. Good morning, everyone. Bwrdd. So a few areas just to highlight. I'd like to add my congratulations to both Sharon as our new Substantive Director of Nursing and to Mark Henwood as our new Executive Medical Director. Great to have you continuing your contribution to this board. A few other areas just to highlight. There's an important joint executive team meeting, and you'll see in the appendix the letter from Judith Paget, the Director General. There's some really important points. We've preceded it in my SBAR report, but I think the letter gives the detail. You'll see that it reflects on our progress last year and areas where we will need to make more progress this year. I think also it gives a reflection on our plan that we produced at the end of March and submitted to them. There are some areas about the finance I suspect we'll pick up in the finance report, although I'm happy to take questions on it at this point as well. Just to highlight a couple of other areas, really pleased to be announcing the change of the end of the temporary service change at Angharad Ward. I know we've announced that publicly, but we need to formally approve that here today. That's due to the sterling work of the team, so well done to Andrew and colleagues on supporting that happen and the teams locally. You'll see also there's an update on the mental health and LD change, which I know we'd be happy to take questions on. And there are a few areas of approval. One of them was the formal end to the temporary service change in Angharad Ward. The second one is around the Welsh Interpretation and Translation Services Collaboration Agreement to approve us agreeing to sealing the deed of variation and endorse the Register of Sealings. But happy to take questions, Chair.
Any questions or observations? Rodri.
Yeah, thank you, Chair. Just one, I think it's a very comprehensive report, just on ophthalmology. Just, I see from there that there's 9 outstanding recommendations, whereas 50 or 59 have already been completed. And it says you've got a clear timeline of March 26 for those outstanding recommendations to be completed. Will we have an update as a board, or or where will this be reported to up until March 26? So that we know that you're on track.
Yeah.
So in the first instance, you're going to see that at the next audit committee. So you'll see through the tracker the work that we've undertaken on behalf of ophthalmology, because the work was undertaken with the medical director, the chief operating officer, myself, and the service to work through those one by one. So you will see it on there, and if there was anything specific, it would fall through the Quality and Safety Committee if there's any issues with harm or safety or quality to the patients.
Thank you.
But you'll see the reduction, and there'll be a narrative in your audit committee tracker, because that was one of the outstanding areas, Chair, where you'd specifically asked for us to have a deep dive into.
Brilliant, thank you.
Andrew, do you want to say anything about that?
Not that specifically, a couple of observations I just wanted to make just in a couple of the issues, so I can hold for a second.
Okay, hold for that. Maynard.
Thank you, Chair. A couple of points, Phil, if I may. First of all, the temporary service change reversal, I think, is great news, and well done to everybody involved in that. I was just wondering, do we have any idea of actually how many people were affected by that temporary change? And the second point is actually on trams, where I'm actually going to disagree with something in your report. Your last sentence there is the impact on however is minimum. I mean, the Transforming Access to Medicines programme is substantially delayed and is costing the Health Board a lot of money. We are having to put in a temporary septic facility at Withybush, and we're having to buy things commercially. So I think that Transforming Access to Medicine programme is having an adverse effect on us, both in terms of our service and our finances.
Yeah, so if I start to come back. So thank you, Maynard. I think that's a really good point. I suspect that Jill may want to come in on that, but I think broadly, if we look at this more broadly as you've done, I think actually the impact is more significant. So I think that's important to correct that. In terms of the numbers of children affected, I know Andrew will want to come in on this. I think we expected a very small number of children to be affected, and I understand that was indeed the case, but I think Andrew will have the numbers.
Yep, thank you. So there were 400 attendances during the period of the temporary change. Only 3 of those children needed to be diverted. 2 of those children were on pathways that would already, even with the reinstatement around how it would take them to Glangwili, either for diabetes or I think there was one Burns patient, a child there as well, that needed to go to Morriston. So only 1 was actually transferred on the basis of the SOP and the change. So 397 effectively of the 400 were managed in Bronglais as per the, even with the change in place.
That's really good. Well done to all the staff in Bronglais for handling the situation.
I'm going to come to Hugh and then I'm going to come to Jill.
Cadeirydd, diolch, and thanks for the question, Inat. In terms of the trams issue in particular, it was more around the business case for the South East trams development, which is expected not to have a significant revenue impact on us particularly, largely because it's based in the South East. There will be a business case that comes through for the South West development in due course, and we'll bring that back to board. We'll bring that back to board because that will have a bigger impact on us as a community. Notwithstanding that, you're absolutely right to pick up. The delays have caused us additional cost and operational challenges locally, so that's very fair to pick that challenge up.
Okay, thank you, Hugh. Jill?
Hugh's covered the point, so thank you.
Brilliant, great, okay. Any other... yes, please, Winston.
Thank you, Chair. I noticed that the mental health and learning disabilities is included in the report, and it's reported that the temporary change resulted in a reduction in routine referrals into community mental health teams in Ceredigion. Was that something that we're anticipating? Is it a good thing that we've seen a reduction, or should we be worried that people aren't referring to that community mental health team?
So I'll bring in Andrew, I think, on that question.
So I think it's more the case that the change necessitates a different pathway for the routine referrals to go through 111 Press 2. So that was the intended impact from making that adjustment. I think just in terms of a bit of broader feedback on that, because that was one of the points I was keen just to update on, is that we've got, since the beginning of March, there's a multi-agency touchpoint meeting in place. It's got representation for mental health primary care, our local authorities and West Wales Action for Mental Health, and they're monitoring the change using data, incidents, complaints and patient feedback. We've got senior members of the mental health team that are attending the Ceredigion Mental Health Forum as well to talk to people that have got lived experience of the change. And to date, in terms of the information we've had, there's nothing remarkable in terms of increased demand through the 111 Press 2 line since that change has been made, and we've had no complaints or incidents reported. So we'll continue to monitor that through those mechanisms and evaluate that after 6 months, as we agreed at the last board meeting.
Great. Winston,
thank you, that's
are you
great.
assured?
Yes, that's great, thank you.
Great, okay. Bill?
Yeah, one item that didn't feature in my report, but I thought I should raise, was that the chair and I and the medical director and nurse director met with a group of families who have children with learning disabilities and epilepsy, because they were raising some concerns about the service provision across our area. And look, it was a very, there were some difficult stories, I think, that we heard. And I know the medical director and nurse director are working with those families to work out how we re-look at our service and the way it supports the families and those children. So what I would hope is that, I'd expect is that that issue will be reported through our Quality Safety Experience Committee Chair. But I did want to raise that so that the board is aware.
Thank you, Phil. Mark.
Yeah, thanks, Phil. Yeah, and just to update on that, yeah, myself and Sharon have sort of been reviewing all the previous work that has been undertaken, and we have a workshop planned next week to look in greater detail into the issue.
Yeah, great. My observation from having met with the families was just partly humbled by how much families do to support their children in these circumstances, and not just a temporary thing. For decades, they support their families, and it feels to me if we manage to calibrate our services right, it has an enormous impact on those families, the quality of life of both carers and the individuals concerned. And there is something about making sure that we can build our service model and our pathway around the needs of those individuals who relatively are quite small, but they absolutely need a service there in place that they can call upon when they most need it. And it was evident to us that wasn't there at the current time. So the more that we can find a solution inside that space, the more I think everybody will be reassured by the process. Jill, did you want to come in?
Yes, thank you. And I appreciate from an epilepsy point of view, there's a clinical element to that. But in terms of learning disabilities, we work very closely with our local authority partners. So I think I would want to see that in any workshop, we make sure that we've got the breadth really of those who need to be there to ensure that we're looking at this holistically. I think that's really important in terms of that process and development.
Well made.
Thank you.
Good point. Okay, just to close this item, can we just note the letter from the Welsh Government following the end of the joint executive team meeting? Yep, everybody comfortable to do that. Approve the formal closure of the temporary service change at Angharad Ward, Bronglais. Approve the collaboration agreement, the Welsh Translation Collaboration Agreement, and agree to the Health Board sealing the deed of variation, which is attached as Appendix 5. Endorse the register of sealings since the previous report on the 27th of March. Note the status report for consultation documents received and responded, and also note executive team discussions. Great, okay, thank you. Let's move to item 8, which is the annual plan 24-25 closure report and the annual plan 25-26. Lee.
Thank you, Chair. So the report we have today serves two purposes. Firstly, to update the board on the 25-26 plan, and then secondly, provide a closure report 24-25. That's a practice we've been in over the last couple of years, is to formally close down the year that's preceded. So I'll just start with the 2024 annual plan firstly. So the report, I think, is quite self-explanatory, but provides a summary of the progress made during 24-25. I won't list everything, but some of the key achievements mentioned include improvements in performance across a number of areas, delivery of £31.5 million of savings and exceeding our financial control total, substantial progress in stabilising the nursing workforce, which obviously we've talked about as a board previously, and completion of Phase 2 of our clinical services plan, which we'll come to later on the agenda also. The report also includes an end-of-year update on the 10 planning objectives, all of which have been reported to the relevant committees. In relation to this year's plan, the board agreed the plan at March board, as everyone's aware, and it was subsequently submitted to Welsh Government. As noted in the report, the Health Board has subsequently received correspondence on the 11th of April from Welsh Government asking us to go further, particularly on the financial aspects of the plan. This was discussed at the April board seminar, and a response submitted as requested by the 30th of April. We are currently awaiting formal feedback from Welsh Government on our plan, beyond obviously the financial aspects. We understand they have reviewed all submitted plans, and we'll get formal feedback as a result of that. We are expecting this will lead to some further dialogue and probably a further meeting or so with Welsh Government officers to consider options in relation to that challenge and potential implications of any decisions we might make in that regard. So I will just stop at that point, if that's okay, Chair, and we can move into discussion. Thank you.
Great, okay. Colleagues, thoughts? Chantal.
Thank you, Chair. I just was one question in relation to the closure of the last year's report in relation to the primary strategy which is behind as far as the closure of that report is concerned. And I can see that one of the reasons for that is because of the lack of engagement. And I just wondered whether we could have a little bit more details around why we've not been able to secure engagement. Thank you.
Right, before we answer that, who are you directing that question to?
Jill.
To Jill, okay. Hold that, Jill. Let's go to Maynard first, and then Winston afterwards, and then we'll come back to answers.
Thank you, Chair. My question is around the urgent and emergency care. It says identified in the brief paragraph, and I'm sure there's much more behind that. Items in Carmarthenshire, particularly hospital at home in Pembrokeshire. I'm just wondering whether things like hospital at home are being expanded into the other counties as well, rather than just left in individual counties.
Good question. Winston.
Yeah, I've got two questions or 2 comments. First one, on the basis that our financial outturn was much better than the control total for last year, has the Welsh Government confirmed the recurrent funding, because there was a sort of dependency on our performance into the current year, and whether there was risk around that? First question. Second question, the letter makes reference to our £11.7 million worth of schemes that we'd like to do. Obviously that creates a risk financially, but what's the risk service-wise if we don't implement those items at an early part of the year? Because we're kind of, it seems to me we're caught between a risk and a hard place in a sense. We want to make sure these developments happen for the right reasons in terms of service safety and performance, but on the one hand we've got a financial challenge as well. So just wondering what the insights of that might be.
Okay, I'm going to, 2 very good points, but what I'm going to do is leave those to the next item, Winston, which I think when we look at financial position, rather than address them here, because I think you've raised an issue that I think we're all concerned about. Lisa, and then we'll come to some answers.
Thank you. Can I just raise a point? In terms of the workforce stabilisation programme, I heard last night that there were some rumours in Aberystwyth University that we haven't got enough jobs for our student nurses. That is absolutely not correct. All of the work that we have done has ensured that we can offer jobs to any of those student nurses. So we are getting in touch with the university today, but just to reassure anyone that could be listening, that is not true.
Great, thank you for clarifying that matter. So, response.
Yes.
Eleanor, sorry Eleanor.
That's quite all right, Chair. Diolch. I just wanted to make a point that it's not a question, but to commend people on the actions that have been taken to get us to this point. It's easy at a board meeting to ask more questions. The fact that several of our areas have been de-escalated is a real achievement, and I'd like to thank all the staff for their work in that area.
Great, thank you. A point well made. Yep.
Shall I just come in first, before Jill comes in?
If you come in, and then we'll come to Jill.
On the general point, so with the planning objectives, we obviously strive to be very transparent and open in relation to what we set out to do in the annual plan that was agreed at board in 24-25, and then through the planning objectives, we track delivery of all the actions within that. So a challenge within the planning objectives is obviously they cover very broad topics, and the position moves quite a lot through the year naturally. So having a one-word description of whether something's on track or behind, whatever, is somewhat artificial. So we have got 2 that are behind. I guess Jill will comment down on the primary community work, but it's certainly the case that obviously through the course of the last year we've had regular updates to committees and boards in relation to each of those areas, and there's there's quite a lot of us, there's a bigger story behind each of them. Some aspects have been completed and made progress on, others haven't. So that's generally how we're approaching it. I think we probably want to think about head through this year how we are a little more sophisticated in how we report progress in a range of areas, because obviously they are covering quite big topics. So just a general point on the planning objectives before Jill comes in.
Thank you, Lee. Jill.
Yes, thank you. And I think that's a really helpful introduction, Lee. So thank you very much. So the wording is, as Lee said, quite general, really, in terms of reporting that. And it was an honest reflection in terms of the original timescale set. But as you'll recall, in probably 2 previous boards now, we've agreed through the board to realign the timescales to ensure that we go out to public engagement at a later stage than it had been originally planned, and that will be in the autumn to align with the refresh of the Health Mid and West Wales strategy. So, in effect, that led to the sort of tracking. And I wouldn't want to infer that we were behind because we've been lazy or careless in some way. It was more that the timescale had been reviewed. Or revised. I think the important point around clinical engagement is something that we should reference. And the stage that we're at the moment is engaging more now with our clinical workforce, our independent contractors, in the stage before we go out to talk to the public around some of the models that we may want to consider. It's really important that we think about those models and how the service may change. So over this next period, and we've got some workshops coming up, we do want to encourage all of our workforce, both internally to the Health Board and externally, to engage with us for that conversation. It's a conversation that's happening across Wales, linked to the primary care model for Wales. And we in this Health Board are also looking more broadly, thinking about systems that operate both in and external to the UK as well. We know that we've got to work differently, and primary care is very much aligned to the work around urgent emergency care as well. So we're having very detailed conversation around the urgent primary care component, and thinking about how we describe and redesign that whole system. And instead of talking about in-hours and out-of-hours, we're talking about services on that 24/7 basis. But it may lead to different ways of working in terms of how we deal with urgent and emergency care and how we deal with those patients who need more consistent and complex and support from their general practice around complexity. So thinking about those different models of care, engaging with our clinicians both in primary care and community services, but also in secondary care, who also need to be able to comment on that wider system. And it's something that I know we're going to get into in terms of the clinical service plan conversation, but that's a whole system conversation. There's a primary care element to all of those pathways, even if some of what we'll be describing today is maybe a secondary care component. So I just want to assure you that we're not technically behind. We've revised the timescales. We are in that phase of working now with our workforce and our clinicians to think about those models of delivery. We're working with the whole system, and we will be wanting to be ready and bringing back to the board and through our strategic planning committee the papers that we'll be taking out for that wider engagement as we get to that point later in the year. So I hope that helps. Thank you.
Thank you very much, Jill.
Thank you, Jill. Very clear. Did you want to say something?
Well, yeah. So I think what Lee and Jill have said is helpful, because I think the word behind is a big word for what is a huge topic. I suppose that there's no doubt that there's a real concern about primary care access across not only our population, across actually the UK, but we hear that loud and clear, I think. And it's something that whilst we're working on the primary community care strategy, I wouldn't want public and board to think that that isn't an area of real focus of the team, and how we do improve access to primary care services more generally.
Could I come back on that very specific point? Apologies, Chair, but it was a challenge Phil did raise with me in the last week, and we've got a very dedicated meeting next week with primary care clinicians, and the focus is access. What does the model look like? Because clearly there are contractual requirements that we would expect our practices to adhere to. But even in spite of that, or despite that, we know that people are reporting they don't have a good experience. So we're exploring that topic with a room full of clinicians next week in response to the challenge from the Chief Executive to put some dedicated focus around that.
Great.
Thank you.
Thank you. Very helpful. Michael and then Andrew.
Thank you, Chair. Yes, I just wanted to I'll commend Lee on, as usual, a very easy to read report. Thank you for that. I just wanted the very last paragraph of the report, in particular the kind of last sentence. Can you just clarify to me exactly what the message there is? Because of course we have got shifting sands and changing demands and challenges. So what's exactly you're telling us in that last paragraph? I was curious about.
Can I just check which one that is, Michael? Is that integrated nature of the annual plan?
Yeah.
Okay. So, so important question. So what we've done through the development of the plan, which obviously we started the process, well, I think it was back in September, October. So the plan has been many months in its gestation, and through that we've obviously sought to look at the individual plans across all the services, bring all those things together, have discussions across services about how to deliver the models that we wish to see. And within that, there's naturally quite a discussion for us to have about the relative balance to strike between things like quality, access, financial cost, which obviously Winston picked up in his question. So the way we've set out to develop the plan was very much to deliver improvement across all of those domains, aligned to our TI de-escalation criteria, so that we weren't targeting one area at the expense of another, essentially. So it's about sustained improvement, but also for the long term. So that's quite a delicate balance to strike. So we've tried to do our best in relation to that, given all the challenges and pressures that exist. So I guess what I'm flagging in that paragraph is if we are to alter one component of that plan, finance, for example, that naturally affects something else. So we need to be quite transparent and open about those trade-offs, and that's why, as I suggested earlier, where that's probably going to need a further discussion with Welsh Government, because obviously the plan was intended to respond to the ministerial priorities and the TI de-escalation criteria. So we've got to be careful about changing our direction of travel in any regard.
I'm going to come to Andrew, and then I'm going to just pull it together, unless anybody else has got anything to say. Andrew.
Thank you, Chair. I just wanted to respond to Maynard's question around hospital at home, actually, and just provide some assurance. So, yes, we are looking at hospital home models across the Health Board. To further strengthen our approach to that going forwards, I know that as part of establishing a set of management and leadership arrangements within the new Community Integrated Medicine Clinical Care Group that meet our strategic and operational objectives, the new service director is also looking at how, for something like hospital at home, we can have somebody leading that across the Health Board so that we have a really consistent approach to the models we're developing, and we move away from perhaps some of the three different ways or three slightly nuanced ways of developing those services that we've historically had. So we are looking at that across the Health Board as part of our urgent emergency care improvement plan, but also we're looking at, as part of the implementing the new structure, how we strengthen our leadership of that in that same way so that we can drive that consistently. Thank you, Andrew.
Thank you, Lee. I mean, my observation would be that it's very good. And back to Eleanor's point, it's fantastic that people worked extremely hard last year to largely deliver the plan as was, albeit there were a few areas that we would have liked to have seen greater progress on. And notwithstanding what you've said, Jill, which I think is important, these things change and alter, so we cannot always deliver as we would want to or aspire to during the course of the year. And I think the same about this year's plan. In a way, the plan has to be malleable enough that we can accommodate, adapt and respond to what we think are the changes that might occur across the year. And I think if we think about last year, there were lots and lots of variables that we weren't in control of, we couldn't predict, but actually impacted significantly upon our delivery profile during the course of the year. And that ranged from additional resources provided to us by Welsh Government to suddenly having to respond to some critical incidents inside the organisation. We are always going to have to think about the consequences of those issues that are not predictable and not within our control when we think about the plan. For me, what's solid about this plan is that it has taken quite a while to prepare. So the preparation for this plan began in the autumn, which is a really good model for thinking about how we plan for the future. It's not something that we just decided at the end of March. It's been long in gestation. Secondly, it kind of integrates finance and delivery inside that space, which is really important. There's no point having a plan if we haven't got a financial framework that supports the delivery of that plan. And as fragile as that is, I think that's evidence inside this plan. And the third element for me is that it links to our strategic intent and our direction. So it's where we would want to go in the future, albeit I sometimes think we have a bit of a strategic vacuum at the moment. We are mid-preparation on our primary and community services strategy. We are probably mid-preparation on thinking through our Healthier Mid and West Wales strategy refresh. So it feels to me there is a bit of a vacuum. And it's important for us to fill that vacuum because people quite rightly can ask us the question, where are you heading when you think about changing these services? And our strategy is our passport to where we think we're heading when we think about those changes. But I can see that alignment in the way it's working. We have to make sure that we can communicate that to the wider public when we think about our plan. But well done to everybody involved in the preparation of it. It's a solid piece of work. Great. Okay, so before we close the item, can we first of all recognise the significant improvement delivered in 24-25, particularly the elimination of the 104-week target and the 52-week outpatient waits, also the delivery of the 31.5 million savings, and the de-escalation of 4 of the areas, all of which are good indicators that we delivered well during the course of the year. Acknowledge the scale of the ambition for this year's plan, which is large, and the challenges around financial recovery, which I think we'll have a conversation about now as we move to our next item. And also the direction of our travel in terms of what we intend to do over the course of the year. The activities that we're engaging in over the course of the year range from relatively small, transactional, but important pieces of work to the quite radical and transformational. So we're seeing that bandwidth across our plan. We have to have the resilience to be able to see that through, in my view. If we are successful at the end of the year in delivering these items, what we will be able to attribute that to is our consistency, our resilience, and our resolve to make sure these things are being delivered well. And then consider the Welsh Government's correspondence of the annual plan, and in light of this, the Health Board's existing investment decisions, which I think Winston, you were referring to, and which I think we'll have a conversation about now. And then endorse the response to Welsh Government, including the aim to de-risk the 31.5 million financial plan in Q1, and to develop plans to improve upon the position in Q2, aiming for a position which is below 30 million. The thing I would say as a reference point is, and I've said it before in these board meetings, every pound that we spend over in terms of our budget is a pound that's taken from another public service. So it isn't a bottomless bank inside Welsh Government. This money is taken from other really important public services that need to be delivered across Wales. So we can't treat it lightly or complacently. We have to, with every possible intention, make sure that we are trying to deliver as best as possible a balanced budget. But at the same time, recognise that what we need to do is future-proof our services and our delivery models, which very much require us to invest simultaneously as we're trying to reduce our expenditure, all of which is an extremely difficult thing to do. But that's the backlog against what we're trying to, where we're trying to work over the course of the next year. Did you want to say anything before we close the item? You're happy? Okay. I think we'll partly continue this conversation on now as we move to financial report for 24-25. Hugh.
Diolch, Cadeirydd. And yes, I think that last point you made there around the trade-off between us overspending and the impact that has on government's other spending commitments, I think it goes to the heart of the challenge that we're trying to grapple with. We've got a bit of a bumper edition of the finance report and the integrated performance report coming this month. That's largely because, of course, we're out of the cycle. We need to bring the month 12 position to the board for noting, and I want to focus more on the month 1 position. If I start off very briefly with the month 12 position on finance, our target control total, as we've talked about for last year, was 31.5 million. That is our target control total for this year. Our outturn last year was a deficit of 24.1 million, subject to audit. We're still going through that audit process, and the audited accounts will come to the board at our next meeting, and of course we'll have our AGM. So we'll have 3 rounds at being able to discuss last year's position. I wanted to just reflect a little bit on the improvements that we saw last year, because in the September board meeting we had a very challenging discussion around some of the choices that we were facing, and the position has markedly improved since then to get to a position under the target control total. There are probably 4 themes I'd want to pick out as part of what changed last year post-September, or post the early summer into the autumn. The first is the macroeconomic climate improved. So we were facing significant inflationary pressures in the first half of the year, which were a continuation of the previous year. Those inflationary pressures reduced as we got towards the tail end of the year. Second one, and those conditions are probably largely going to be maintained now, I envisage, going into this year. The challenge for us this year from a macroeconomic perspective is potentially what impact tariffs might have on, in particular, medication, and the impact that national insurance increases will have on our supply chain. Those are the 2 remaining issues of concern. The second one is that we did focus on one big theme last year under Lisa's leadership, under Sharon's leadership. Addressing our use of agency nursing has had a very significant impact on our position. So much so that we're down to a position in month 1 of this year where we spent £245,000 on nurse agency in the month. That is a phenomenal improvement from where we were 18 months ago or 2 years ago. So that position is the lowest that we've got on record, and certainly the lowest that I've seen since I've been with the organisation. So a really impressive improvement there, largely thanks to the nurses who we were able to recruit from overseas. Thirdly, our work on grip and control has really borne fruit. Our financial control subgroup is a group, and I'm grateful to the support that Lisa and Mark in particular have as part of those challenging discussions we have at that group. We forensically review any new commitments to expenditure that the organisation seeks to make. That has had a demonstrable impact, although difficult to quantify the impact. Inevitably, we are taking judgments in the heat of the moment in that meeting, and that means that there will be occasions where we want to reflect and refine our approach, but because we meet on a weekly basis, that is sufficiently frequent for us to do that. And lastly, what we saw last year was a response to our escalation framework from a number of directorates. In particular, Ceredigion and Pembrokeshire had a demonstrable improvement in their financial position, but other directorates didn't demonstrate that same improvement. So as we go into this year, a number of our challenges remain. The target control total remains 31.5 million, and we need to make sure that we deliver against that and go further, as Lee alluded to. That's the ongoing dialogue we're having with Welsh Government. The plan going into this year did identify the savings requirement that we had as an organisation. The challenge we've seen in month 1 is not one of cost containment. We're actually in line with our budgets in terms of core costs. The issue that we're seeing is the inability to translate those savings plans and commitments that were made during the planning cycle into deliverable actions. We've got a process in place now through the escalation meetings to reinforce the delivery that we need to see coming through. Our financial control subgroup remains in place, and as I said, the risks are broadly around the macroeconomic position on tariffs and national insurance. We've got one big theme that we're taking into this year as well. As an executive team, we've committed to working on our urgent emergency care challenge, and that is an area which we know is, as well as not providing optimal outcomes for patients, is also wasteful from a financial perspective, and an area that we need to focus on. So that's the summary of the position going from last year into this year. Just responding to Winston's question on recurrent funding. So there were a number of conditions attached to the conditionally recurrent funding that we received last year, one of which was to get to target control total last year, so tick on that one. One of the key issues for us, though, is that we need to have a demonstrable plan that improves our financial position so we get to sustainable recurrent balance. We're not there yet. We're waiting for the comprehensive spending review in order to determine what the income allocation will look like, and clearly we are working internally to determine what our expenditure profile will look like, and we'll bring those together. I hope very much to bring that to the board in the early autumn so we can determine what our integrated medium-term plan needs to look like as an organisation. Chair, with that, happy to open up to discussion.
Thank you, Hugh. Winston.
Yeah, thanks for confirming that number, Hugh. What was the actual amount? I thought it was tens of millions that we were expecting.
26 million, if I recall,
26
is the conditionally recurrent funding.
So I just want to echo, I think the organisation's made a fantastic achievement last year in meeting and beating the control total. I think I can last remember the organisation having a 24 million overspend some 3 years ago, so that's a fantastic achievement. I just want to move on in terms of month one, that picture, which I think is something that we ought to just consider as a board. There's a table which looks at the in-month financial summary, and it's really, really helpful on this page 270, but it gives a reported position and a comparison to the previous month. I just want to highlight continuing healthcare, because the in-month figure's 5.2 million, but the month before was only 2.6 million. So it's effectively doubled when comparing one on the other. And I know that the anticipated plan was 5.1, so we expected that. Well, it would be helpful just to have an understanding of the underlying factors related to that, in a sense. And then the other area I just wanted to pick up on briefly was around the medical rate card and that particular challenge that this health board and other health boards have had. To what extent are we working with Swansea Bay or other health boards on that? Because it seems to me it's an issue bigger than this health board that we need to look at. So those are just the two things I wanted to just pick up on.
Very helpful. Any other questions that people want to ask? And then Michael, and then Maynard.
Yeah, I'm just curious on one thing you just said, Hugh. You talked about the financial control subgroup forensically reviewing impact of decisions. I might have made this wrong. Then you said, although it's difficult to judge impacts. So how do we kind of, ideally, one would want to be able to judge impacts. Is that right? And how do we do that, do you think, going forward?
Yeah. Hold on to that question. Maynard.
A few questions. My biggest concern is around savings. We told the Welsh Government that we would be using the first quarter to de-risk our plan. And yet, in our last board meeting and in this board meeting, we're reporting that no new additional saving schemes have been identified. I'm concerned that if we're not identifying new schemes, then delivering that £44 million worth of saving gets increasingly difficult every day we go into this financial year. That's my biggest concern. Winston's touched on one of the other things. The other one I wanted to touch on was the ministerial enablers I mentioned there, and actually understanding how close we are to being able to deliver those. We're asking for a further 30% saving on agency. Now we've already, as Hugh mentioned, we've already really impacted the nurse side of that. So actually, further reducing that gets increasingly difficult the more you reduce it. So there's that. We're asked to reduce healthcare support workers and admin staff agency to 0 by September. You know, are we getting close to that? What is the current percentage in our job planning? We're asked to achieve 90% in that, and also we're asked to reduce our sickness levels. And I've got no real flavour from the report how close or how deliverable those things are.
Good challenge. I'm sure Lisa might want to come in on some of those items as well. I tell you what, we'll take responses to those, and then I'll come back to Chantal and Eleanor. Hugh.
Great, thank you. So if I start off with CHC, Winston, the expenditure, the monthly expenditure we see in CHC is about 67 million each month. And of course, the step change that we've seen in month. So firstly, it can be an area that's quite volatile as we see new cases and new packages, particularly within areas like LD, which are inherently expensive. The second issue that we've seen as a step change from one year to the next is the impact of national insurance contributions, obviously on our suppliers and our care homes. That's having a significant impact on our cost base. That's the first issue. In terms of the medical rate card, I might ask Mark to comment on that, so I'll leave that hanging for a moment. Financial control subgroup judgments that get made, inevitably we are working in real time and the information we receive isn't always as robust or full as we would wish. So we're having regular conversations with our CCGs, and where we aren't in a position to approve in 1 week, we can then ask for more assurance and bring those challenges back in the following week. That's what I mean about we can't make all the judgments in real time. Sometimes we need to ask for things to come back in future meetings. That does mean that there are sometimes delays that get put into the recruitment process. That's in terms of needing to make sure we get adequate assurances from our teams. Maynard's questions then on de-risking the plan. I agree, it's a real concern in terms of the dearth of new savings that have come through over the last few months. We have had our first round of escalation meetings with our new CCGs, and a deadline of the 23rd of May, which is last Friday, was given to our CCGs to provide additional savings for us, and we saw an additional 3 million coming through as part of that deadline. And obviously that's not made into the plan, but it will make it through to future iterations. 1.6 million of that was in community integrated medicine, 0.8 in mental health, and 0.2 in each of facilities and planning. So we've now got our full identification of our recurrent savings. The issue of our recurrent savings, not our non-recurrent. Our recurrent, the issue is converting those from plans which we would rank as red, as in highly risky, or blue, which are ideas stage, to deliverable plans, which would be green and amber. So that's the challenge for our teams at the moment. And the last point around the Welsh Government's requirements to reduce our agency by 30%, admin and healthcare support worker agency to 0, job planning and sickness levels. We will be bringing that back as future iterations of this report, both into Financial and Performance Committee and into board. We didn't have an opportunity to do that in month 1. I'm confident actually in our position on agency, given our starting point last year and our baseline measure, we will see a demonstrable improvement. And in terms of admin and healthcare support workers, but clearly there's still work to do. Job planning, of course, we have improved our position quite significantly on that under Mark's leadership, and sickness levels remains an area of concern and challenge, which I'm sure will be reviewed through the People Committee.
Great. I'm going to come to Mark, and Sharon, did you want to respond to these questions? Hang a moment. Okay, I'm going to come to Mark, Lisa, and Sharon, and then I'll come to Eleanor, Chantal and Anna for the next questions you want to ask. So Mark first.
Thank you, Chair. So yeah, job planning at the moment is at 85%, and that's been fairly stable for a few months now. We were up to 86%, so I think we have a degree of stability. All the areas that are not performing over 80% have action plans in place that we're monitoring actively on a monthly basis. So I think we're sort of there now between that sort of between 85 and 90%. I'm hoping to get to 90%, but it may be 85 to 90 is where we're gonna stay. On the rate card, Winston, we undertook a piece of work towards the end of last year to look at a health board rate card. As you know, the rate card has been an always rate card has been in place since 2017. Some health boards have changed theirs, updated theirs over that period of time, but none of them particularly recently. We were just commencing a process of engagement with our local negotiating committee on that towards the end of last year, when we had some intelligence that there was likely to be progress on an all-Wales rate card. I have had some recent information about that. The work is progressing, but probably not at the rate that we would like. So I and my team have been looking at considering a new rate card for just us as a health board. As part of that, we've looked at the rate cards that health boards across Wales are using. I think it's safe to say there is a lot of variability in rates and also in the various criteria that they use to decide upon those rates. And we are bringing a paper back to formal executive team very soon to look at that. There have been some complicating issues that have made a rate card difficult. The BMA produced their own rate card with quite high rates, and those played out significantly during the period of industrial action, where we were at some points having to pay quite high rates. I think, as we know as well, across the UK, talk of industrial action is reoccurring now. But the current plan is that we are going to bring a proposed rate card back to the executive team in June.
Thank you. Sharon, Lisa, and then I'm going to come to Andrew.
Thank you, Chair. Diolch. I was just going to come back really on the request around the impact of the decisions made at Financial Control Subgroup, and just to emphasise really that there's communication between that group and the Quality Impact Assessment Panel as well. So anything that goes through that process, there is a request for Quality Impact Assessment as well, if so that we can monitor what the impact might be aligned to the domains of the duty of quality.
Very good. Good. Okay. Lisa.
Thank you. So my response is in regards to the agency reduction. We had a detailed update at the People OD committee earlier this week, which went through all of the work streams for each of the professional groups and the progress that we're making. For assurance, we have no agency workers in estates facilities or admin and clerical, so we've already met that target. The plans that we have in place have already met the target for nursing, and with the further actions, we will overachieve on that 30% reduction. So the two areas of focus will be medical and allied health professions and health sciences, which will be more challenging, but we did have quite a detailed update on Tuesday around the progress of that work.
Very good. Good, okay. Andrew.
Yeah, thank you, Chair. I mean, I'm happy to wait if you want to let IM colleagues ask questions. I'll come in because they may pick up some of the issues I wanted to comment on. But
okay, let's hang on a moment. So I'm going to come to Eleanor, Chantal, and then Anna.
Diolch, Cadeirydd. I've got a few questions. Let's start in order. The underlying deficit, are we doing any work on productivity which will help us reduce that deficit next year? It's a great report, but I think we've talked about productivity in the past, and I'm wondering if we need to start reporting a bit more on it. Second question for me, Sharon touched on that, the link between the finance subgroup and quality. In looking at the escalation departments, there are some that are red across all of them, and the one I am probably most concerned is about mental health. It's not just about saving money, it's a fragile service. And what are we doing about that? The third question for me is, we've moved to a new clinical leadership model. How are the responsibilities for savings and quality settling in that group? And are they having an impact already, or are we waiting to see that? And I suppose my final question around this is around a more practical question, the secondary care drugs. That is beyond budget already. It's always increasing. I suspect there are some good stories about people in there, but I'm intrigued to know, how does that link with our population compared with population across Wales? Are we spending more when actually primary care prescribing seems to be on target? And sorry if you didn't catch most of that.
Okay, just taking it, using Chairman's prerogative, my view on the prescription, you know, both, if you look at the budget, both secondary care and primary care, prescriptions and drugs, it's 10% of our budget. It's 10% of our expenditure. £13 million we spent in the last month on just providing drugs, which equates to around £38 per person across the whole of the 3 counties that we spent last month on drugs. There must be some way in which we can kind of increase our invigilation over the expenditure of these drugs, ensuring they're absolutely necessary and what we should be doing. Sorry, that was just me quipping in. Chantal.
Thank you, Chair. I think a number of the questions that have already been asked by IMs is just, from my perspective, having a better understanding of that reliability of the forecasting model that you're using in order for us to be able to have that reassurance that we are on track, that all of the measures that we're putting into place actually will allow us to deliver. That's one of the issues. And how confident are we on the internal financial controls, which allows us to be able to monitor what's going on within the organisation in order for us to be able to, because, you know, when I was looking at that map, if you like, with so many reds in that map, that's kind of makes me feel a little bit uncomfortable, in the sense that, have we got that level of control, that level of grip within the organisation in order for us to be able to come back to the board and say, these are the things that we've done, these are the processes that we're following in order for us to be able to deliver on those savings.
Good questions. They also suggest to me, Chantal, that there is a degree, we need to have a risk appetite around some of these high-profile circumstances that stretches. We might not be able to resolve all of these things to our absolute satisfaction and assurance at this moment in time. We need to manage our risk around this as we continue throughout the next few months on some of these issues. But we do need assurance the right structures and systems and invigilation is in place to manage this over this period. Before you come back, Anna.
I think my question's been asked more or less. Thanks, Chair.
Great, okay. So in terms of response, Hugh.
Jay, if I start, and then I'm sure I'll bring colleagues in. So if I start with, Eleanor, your questions on underlying deficit and productivity measures. So our team they're currently working on the productivity report. It is challenging, and if it was easy, we'd have done it a long time ago. It is challenging, but we are now in a place where we've got an indicative dashboard that we can bring through to the Finance and Performance Committee, which I'm sure the Chair F&P will be delighted with, because Michael has asked that question a number of times. We are also responding quite naturally to the MAG review, and that will inevitably drive a focus as well on productivity, but it's an area that I think we will increasingly report on and become increasingly transparent on. Second issue around escalation and the areas that are continually red, and probably, Chantal, your question as well around our work, I'll ask Andrew to comment on, but very briefly, I'm pleased you're uncomfortable with that, Chantal, because it is an uncomfortable position that we're reporting. There are too many areas in escalation, But we do have a transparent framework in place now that is reporting our concerns and our challenges to the board. So our escalation and financial control subgroup is the route by which we're getting assurance or not getting assurance, and we're able to address issues accordingly. There is a lot of work that is being done to support de-escalation, but I'll probably ask Andrew just to comment on that, because he's probably closer to that work. Likewise with the CCG leadership question that you asked, Eleanor. Secondary care drugs is an area of real challenge for us. It's an area of challenge across Wales. So there is benchmarking that gets done. And the last finance leadership report that went to chief executives and finance directors provides some benchmarking over the changes from one year to the next in those areas. And I've already shared that with Jill and the team in terms of other health boards that are predicting less of an increase than we are in our cost across secondary and primary care drugs. It's not a uniform field, of course, across Wales. And yes, we are seeing an increase in those areas, partly because of what medication can now do and deliver, and the increasing demands that we're seeing there. So we've brought a report back on that before to the board. It is an area that we will need to make sure there is a deep dive going into FCSG. It's on the work plan for that, but we did have a deep dive into our internal value and sustainability group last week, which provided us with assurance from the medicines management team on the work that is being done to manage expenditure in that space. Chantal, I'll then ask a question about our forecasting model. We've got a cycle of forecasting that we undertake within the finance team, and that's subject to check and balances. So in terms of our monthly cycle, we have a flash report on our financial position on day 1 of the month. Then on day 5, we provide our forecasts into the organisation. Those forecasts are over the rest of the financial year on a monthly basis, and we check back to that forecast when we come to the next reporting cycle. So we always have a learning loop in our forecasting process. So hopefully that provides you with assurance there. But Chair, I might ask Andrew just to comment on.
Yes, please. Andrew.
There's a few things there, I think, for me to pick up. So I've got a list. So if I could start with mental health and learning disabilities first, and the question from the Vice Chair. So agree, there are, obviously, with the escalation levels across a range of domains there are a number of concerns, and there are some fragilities in that service, as we know, in terms of workforce. And we've got the temporary change in place in North Ceredigion at the moment, which is evidence of how some of those manifest. I have, in the last week, so colleagues may or may not be aware, there is a former mental health trust chief executive from England currently providing some support and advice to our neighbours in Swansea Bay around their mental health services. And via some discussions at the Regional Joint Committee, I have linked and connected with that person, Melanie Walker. She met with myself and the senior leadership team in mental health on Friday, and we had a really good conversation just around some of the challenges, some of the issues, and it helped, I think, prod and probe some other areas and lines of inquiry to think about in terms of tackling some of the issues we've got that will, I think, play through across all of those domains, ultimately recognising that, as we've said here before, some of the issues are about process and improving process, so they're not necessarily big service issues, they're management issues. And I think, I don't want to preempt the performance report, but I know in the last week we've had a de-escalation plan for a number of the process issues that the Directorate are facing that we've received, that we'll be able to validate and test now as we go into the next round of recovery meetings. So I'm optimistic that what that will do is help us start thinking about, to some extent, what the next steps for mental health and learning disabilities are as a service in terms of some of them, or where they go next in terms of some of the strategic direction, how that links to the new mental health plan that's been launched, the mental health and learning disabilities plan that's been launched nationally, and the strategic elements of that. And of course that bases itself a lot on some of the learning from Trieste, and our service have been long linked with a partnership with the team in Trieste around, and formed a lot of the basis of the original transforming mental health strategy. So I think over the next few months, I've tasked them with taking away. There were about 5 or 6 things that came out of that meeting that I've tasked the team with going away and working through now in terms of how we develop a sustainable approach to mental health that will hopefully, I believe, make progress across a number of domains, including how we address some of the financial sustainability issues that we've got there as well. The other couple of areas I think I wanted to just touch on, obviously the question around the clinical care group impact is something that I'm monitoring and watching really closely. I'm mindful that with the month 1 report, that was 4 weeks into the launch of the clinical care group structure. We're now sort of 7 to 8 weeks in. I'm encouraged from some of the conversations I'm having with our senior leadership teams in those clinical care groups about the actions and the steps they are taking, in particular in relation to savings and financial delivery. And only this week on Tuesday, I believe over the next few weeks we'll see some of those plans move forward in a positive way. We now have, which we haven't had before, for example, for planned and specialist care, we do have on paper a list of schemes that would deliver their full savings requirement. The challenge for us, as we discussed with them initially when we first saw that in the recovery meeting, is how we now translate some of those into amber and green deliverable schemes as well. All of the service directors are taking a view on their undercurrent their non-recurrent and underspending in month and towards the end of last year, because in doing that they've all taken some deliberate actions to hold posts or change services or do things differently. And I'm encouraging them, and they are proactively doing this, looking therefore at, as we've done that, what would be the impact of us making that a permanent change, or how could we deliver some of those changes more permanently to realise that underspend and convert that into a recurrent position. So just within, again, I'm not picking on plan care, it was just because there were some big numbers there, that they'd identified within their revised plan £3.5 million benefit around medical variable pay. They believe on the basis of the actions they've taken in month 1 and month 2, they have potentially already delivered that £3.5 million. And their forecast position could be as much as £5 million benefit on that. So they want to be certain with their senior finance business partner that will translate. But that's currently a red scheme in our savings plan, so it doesn't feature as as something that we're delivering. So I think there are some positive signs there about their approach and the steps they're taking. I think in terms of some of the I think the fact that the core budget is underspent, it's not often I've been, apart from the last couple of months of the year, it's not often I've been in a position where the operational core budget has either been in balance or underspent. So that's, for me, a sign as well around some of the increased scrutiny that's going on at an operational level. And I think the other steps that they've all taken is they're actually really keen to tighten some of our financial control procedures at clinical care group level. So they are very clear as service directors. They want sight on everything going out that's over £5,000. That's a much lower level of delegation than we've historically had, or a change to our hierarchy that we've historically had. So, and that's been initiated by them as a way of them having real oversight and control of what's being spent. So there's there is some steps they're taking to provide additional grip. And finally, one of the steps I've taken is I've asked one of my senior team to take on a bit of I suppose it's almost a program manager type of role, but to give me an independent litmus test of where we are with all those savings plans. So I'm conscious that I tend to be quite positive and optimistic, and I've selected somebody that balances that really well. So the purpose being that I get a really independent and objective assessment through someone else's eyes and litmus test, what savings plans do we have? Do we think they're deliverable? And are there really clear actions that sit behind each line on those plans that will deliver them with a time frame and a lead owner, so that we can see how that profiles then into our financial position? They started doing that a couple of weeks ago, so I think over the next 3 or 4 weeks we'll see some of the plans, or I'm expecting to see, and I made this clear on Tuesday with the senior team, I'm expecting to see those plans materialise and become far more granular, but I think that'll help give me better assurance as to where we truly are in that position, because if they don't make sense to that individual as a set of plans, they're not going to make sense with me sat here in front of you as a board. So I think there are early signs, recognising we're sort of 7 or 8 weeks into that, but I'm hoping and expecting by Q1 that will start to translate into some of the information then we're seeing in the reporting position. But
Thank you.
I hope that helps provide some assurance.
Thank you, Andrew. That was comprehensive. I'm going to close the item because we need to move on. But Phil, last word.
Thanks. So I mean, I think it's been a helpful discussion. Andrew bringing in that operational detail, I thought was really helpful and in building our confidence as to what's going on at ground level. Look, we've set a plan to get back to our control total, the 31.5 million. At the moment, 1.3 million over month one. Have to remember, if we carried on at that rate, we'd be into the mid 40 million. So need to remember that at a high level, and the expectation clearly you'll see from the letter, from the JET meeting and the scrutiny meetings that we've had from government, is that we go further than our target control total, and that's based on the fact that we got to 24 million last year. So we are going to have to be really clear on our path to delivery, how we de-risk our plan, and what options we have to go further. There's some real tensions and trade-offs, as Lee described, I think, between quality, access and finance, and I think we were really careful when we constructed the plan to try and balance that out. I think we also balanced out short and medium and long term in our plan, so we were really mindful of that. Conditionally recurrent funding is based on us getting back to zero in 3 years' time, and of course if we do something drastic in year one, it could affect us delivering over the next few years and indeed for the long term. So that's how we constructed our plan, and it's a really careful balance we're going to have to think. In terms of Maynard's point, which I think you've said last time, that our history is that we produce a savings plan and then we deliver 50% of it. And I suppose, therefore, the question of, well, where are the other savings that we're producing is an important one. So I think Andrew's given us some confidence there on the way the CCGs are starting to approach that. And I agree, we've got new managers in many of those positions who are now re-looking at this and taking their accountability very seriously. Some of them have started since the previous savings plans were produced. So I think they're rapidly working on that, and having spoken to them all, I felt some confidence about the way they were approaching that. I think also the executive team have looked at other potential choices for savings plans, which we've been looking at. I think I would expect those to be coming back to exec team, but also through the finance committee. I'd expect us to see that through the finance committee as we work through this. But we do have to just be really mindful about the balance between quality, access and finance, and also short, medium and long term as we go through that process. But thank you very much. A detailed look at our financial position.
Great. Thank you, colleagues. That was, I think that was really helpful. And thank you, Andrew. I think you gave us quite a lot of assurance in your response to the kind of the governance, the architecture that I think we've put in place here to try and ensure that we set ourselves challenging budgets and we stick to them. Hugh, you're right. I don't think this is a reason for us to feel comfortable. I don't think, frankly, I think if we're looking to be comforted, then this is not the place to do it. It's going to be a challenging year. There's going to be lots of difficulties and contentions throughout the year. We just have to accept the fact that there is a degree of risk that we will run, Chantal, as a board around our savings, around our expenditure over the course of the year, and around our investments as we think about the technologies we want to invest in as well. So I think that's probably critical. I think the more that we can see, I mean, my initial response to the to the graphic showing where we have some room to make some changes was that it's transparent, it's honest, it's disappointing, it's open. And my final question was, where is the managers? Where are the managers in this process? Because I would expect managers to be able to grip this situation and at least, you know, work within a framework of delivering some of those cost savings that we're looking for. So there is something about how do we help people do that. For me, there's also something about the fact when you ask an organisation to save quite a lot of money, we need to build a sense of fiscal literacy around how people do that, because I'm sure people just worry about making those savings over the course of the year without necessarily having the guidance about where they can best be made. And back to your point, Sharon, we cannot make those savings at the cost or risk of the quality or the safety of the services we're delivering. Fundamentally, that's not a compromise we can operate in. So for all kinds of reasons, I think last year was a learning curve. I suspect this year will be much the same. Just in terms of what we need to do to cover that off, so just note the kind of the position in relation to the Health Board's unaudited end-of-year position is 24.1 million, and I think we've scrutinised the executive delegated officer portfolios, which have overspent against the delegated budgets. I think we've followed through on that as well. We've had a fairly healthy conversation. And acknowledge the status update for signed budget delegation accountable officer letters. I think more needs to be signed.
All done now.
Fantastic. Great. Good. Okay. That's reassuring. Brilliant. Okay. Let's just cover off our next item, which is Integrated Performance Assurance Report, and then we'll take a refreshment break.
Diolch, Cadeirydd. A comment the Chief Executive just made there around these being detailed papers just did make me reflect that these are the microscope papers I think we see as a board, and we need to, I guess, in discussions be able to move from the microscope to the telescope and back again in terms of our scrutiny and review. Again, two papers for IPA. One is the month 12 position, and in particular, I just want to refer the board to the assure elements in month 12 around the planned care delivery position with 0 outpatients, patients waiting over 52 weeks, and no one waiting more than 104 weeks on referral to treatment, and the number on referral to treatment pathways over 52 weeks being the lowest since December 2020. I think that is a phenomenal achievement through hard work across the organisation, and congratulate the teams for getting there. Naturally, though, there are still areas of concern which are very clearly articulated in the paper, and I'm also very conscious, particularly at the end of the year, to recognise that at the end of every statistic is a person who is affected. As I move into month 1, I just want to recognise that we've changed our report. So New Year is a good opportunity to change both the finance report and the performance report. We have changed the report so we become a lot more targeted and forensic in the way in which we're able to articulate the challenge that the organisation is facing. And I'm very hopeful that that will generate a different discussion as we go into this year through our board considerations. Of particular concern in month 1 is highlighted on page 3 of the SPAR for the IPA, particularly around areas like mental health and urgent emergency care. I also want to reflect that our planned care position has, in month 1, reverted somewhat, and is down there as an advise area for the board to consider. We've also included within the report a position which triangulates our key metrics and which provides a summary of our escalation position in a slightly different format to previously. We'll be refining our escalation position again as we go into our next round of reporting, because that will be very much based on the new CCG structure from the end of month 1 reporting onwards. So, Chair, with that, happy to just open up directly to discussion.
Rodri.
Yeah, thank you, Chair. Just a couple of points then. If I look at the workforce staff sickness, obviously, if we look at month 12, the rolling average was 6.6%. It's kind of, in month 1, it's slightly increased to 6.18%. I just want to know if there is kind of, I don't know, if it is improving for a reason, because of looking at the report, there is a deep dive into estates and facilities and also on scheduled care. And I was just wondering, regarding estates and facilities, looking at the escalation overview, I don't know if you can just give us a slight overview of what is happening there, because there's a lot of kind of worrying trends in estates and facilities, and also most probably correlation between that and staff sickness. So I just wanted to know if there is kind of an improvement there, and if this deep dive, if it has started, kind of if it is making a difference.
Lisa, before you come back on that, my question linked to that would be the ratio between long-term and short-term sickness. Because my understanding is long-term constitutes 2/3 of our sickness absence, which is very different from short-term sickness. I wonder what we are doing inside that space, or might do, to mitigate that, that significant volume of staff who are on long-term sick. And do you have a view on this?
Only from the report from the PODC and staff updates from...
you speak up, Anne? Sorry, it's not picking it up, sorry.
It's only from the Staff Partnership Forum and PODC that we have the figures, and when you look at the figures you think, oh dear God, but then when it's broken down, the 1/3 are short-term sickness. The long-term sickness are really a lot of stress and anxiety, and that's coming over 6 to 8 months before they're even fit enough to look at coming back to work. Now that our psychological services have got more staff in it, we're getting more seen, because we have to use a lot of external counselling areas like the RCN, Viva, Canopy, and they could only do phone consultations, so people weren't actually seen. And of course we do have workforce issues, and the fact that we only have one doctor covering, and he can only see people as slot-in times on Teams. So.
Okay, helpful background. Lisa.
Okay, thank you. So in terms of estates and facilities, I can confirm they have seen a significant reduction in their sickness absence rates. There are 2 other service areas that noted a reduction between March, April and then May. The reason for that, because I did ask the question, is this a coincidence or has there been targeted action? So there is now a member of the workforce team meets weekly with the management team within estates and facilities and the supervisors, and they go through all of their staffing positions. So there is a very targeted approach to return to work interviews, to occupational health referrals. So the actual process management is now in place. That is the same in the other 2 areas where there was a reduction. In terms of the long-term sickness, again, we had an excellent presentation at the People and OD Committee this week around our Recovery in Nature programmes. So for staff who are suffering from stress-related symptoms, they're not necessarily off sick, so this could prevent people from going off sick. There is a detailed process that an individual will go through in terms of assessing suitability for the longer term programme or the very short 1-day programme. And we heard 2 staff stories of how we've significantly improved their health. One individual who quoted that they now weren't on antidepressants as a result of going on the programme. So we're definitely targeting the stress-related absence through our Recovery in Nature programme. The other piece of work that we are doing with our public health colleagues is there's a study taking place at the moment with Public Health Wales and our organisation. So rather than looking at our sickness absence based upon where people work, we're looking at where they live, So can we are there any trends between our staff sickness and the epidemiology of their local population? And the very early indicators are, it is looking as if the reasons for people being off is linked with the population of their geography. As that work progresses, what we want to then look at is, do we need to tailor our occupational health and staff wellbeing service differently for those different areas? So it's very early days, and it will be used as a piece of work that hopefully can be replicated across Wales as we start to get more information.
Thank you very much. Roger, has that given you some assurance?
Yeah, I think that's good news. So hopefully things will get better again.
Very good. Colleagues, any other questions? Ewan, and then Anna, and then Maynard.
Yeah, just following up really in terms of the staff sickness. And it's great to see in terms of the differentiation between the long-term and short-term to give us that kind of trend. But when you look at the kind of headline figures, I mean, we've got a staff population of about 12,000. There are just short of 500 who are off on long-term sick. And you think of the impact that has on services. But in terms of welcoming Lisa's comments in terms of looking at some of the kind of place location kind of correlation in terms of sickness, I'm just wondering, in terms of, in addition to the in-house programs that we've got, is there an opportunity to perhaps to engage in those communities where there is a correlation with some of the community prevention services which exist? I'm thinking of various different community organisations who offer that resilience around prevention, but also in terms of well-being, who may be able to kind of fill some of the gaps, because looking at our arts and health programme, there are waiting lists already for that, and that's for kind of patients. So in terms of our staff, could we kind of look at the correlation in terms of the place-based data to help our staff in terms of, rather than waiting for our in-house services, utilising those existing and proven prevention services within our communities, who would be more than happy to work in partnership?
Very good thought, and I think as the data, as the Public Health Wales data and the Health Board data start to expose some of that, it might be a really good idea to take forward. Very good. Anna.
Yeah, thank you, Chair. I think my comment or question really builds on a similar issue I raised last time, and that is my increasing discomfort that we're seeing in the IPAR narrative, staff metrics in one form or another featuring quite prominently in a way that we didn't used to, and simultaneously we're reporting reductions in incidents in our quality and safety metrics. And I suppose on the surface we'd think a reduction in incidents is fantastic, but of course they're only the reported incidents. And then if we look at the workforce metrics, particularly the engagement and speaking up metrics that we've got, and we've got a subsequent paper on this around the staff survey, alongside our incident data, we need to countenance the possibility that we've got this sort of notion of silent quitting going on, and that people are not reporting in the way that we would want them to do for reasons connected with their levels of engagement, burnout, disillusionment that actually anything happens when they report. So I wonder if we've been able to make any progress since I raised that issue last time round to explore the possibility that that could be at least part of an explanation for these deteriorating metrics, and what ongoing work there is so that we can remain sharp to that possibility that there is something more concerning going on in our incident reporting.
Good question. Good question. And I do think we need to correlate more the data that we're being exposed to. And maybe we'll come back to this a bit more when we look at the report this afternoon on the staff survey. But an initial response would be helpful.
Yeah.
Sharon.
Thank you, Chair, and thank you, Anna. You raised a valid point this time and also in the previous meeting as well. And I know we're going to be talking about the staff survey later on this afternoon, but in particular the patient safety, the positivity score for patient safety, although it increased last year compared to the previous year, it's still not where we would want it to be. And I think our view is that we want our staff to feel as safe as possible in reporting errors, near misses and incidents, and we want to make sure that they're treated fairly then when they receive, and that they receive the feedback following the review of those incidents as well. So I've spoken with my team in particular and asked them to review those feedback pathways with the services to make sure that that feedback is received. But it links very closely to organisational culture as well, as you say, and the Speak Up agenda that we're promoting as well. And we need to make sure that we continuously embed this and make sure that our staff feel safe to speak up. We have got a paper coming to QSEC next month, so that we'll go into that in more detail with some of the actions that we are proposing and taking forward. And reflecting on your comment last time around the number of incidents that we're seeing, you know, you're right. We don't want to see the number of incidents decreasing. We'd like to see the number of low incidents actually increasing, but we'd like to see the number of moderate to severe harm decreasing. So again, I've asked the team to look into that over the last 4 years so we can see a trend. And we'll report that into QSEC next month. I'm not seeing anything obvious standing out at the moment, and I am seeing a reduction in falls, in the harm according to falls incidents at the moment. But I still want to do some more analysis on that before we bring that into QSEC. But I think they're really important points, and we need to make sure that we turn all this data into meaningful information, and then we can drive improvement going forward.
Okay, I'm going to come to Lisa, and then if there's no other burning points, I'm going to close the item.
Okay, thank you. So having looked at the patient safety elements of the staff survey following the People Committee earlier this week, the actual question that was linked to my organisation encourages me to report is 72%. So it can, even though that was a not great response for us around patient safety, people did feel able and were encouraged to report. The one that we do need to focus our attention on, though, is, and I have feedback of changes made as a result, was only 46%. So there's definitely something that people are encouraged to report, but we've got to close the loop to keep that level of engagement.
Great. I have a sense we will come back to this afternoon. Yeah. Maynard.
Totally different subject.
Okay.
One of the targeted intervention targets is 3 months of single cancer pathway target over 60%. Great, we got 65% in March, but there's no April figure here, which would have been our 3rd month. And I suspect we'd be singing and shouting if we'd actually hit 60% in April. Just wondering whether we've got any indication of our figures for April.
That's a deeply cynical approach there. Andrew's going to tell us something different now.
I hope not. I'm confident that April performance will be above 60%. It might not be quite 65, but it will be between 60 and 65.
I suspect it's just the delay in the data.
Yeah.
If I have a frustration about the papers, we're looking at data that's 2 months old, and it's not because it hasn't been shared. It's because it hasn't yet been analysed or validated. Good question. We'll hold on. We'll hold you to that. Okay. Hugh, and then.
Chair, you've answered the question, which is it's 2 months out of the data is always 2 months old for cancer.
And be assured, it's not being withheld from us, the data. No. It's just that it's the way in which it's managed. It is a bit frustrating. I feel as if we talk about old data, and things can change so quickly. We know it's such a volatile space. Fine. Okay. Anything you would want to say?
Just a couple. Well, on that point, on the cancer target is 80%. Our targeted intervention de-escalation is above 60%, which is, to get it consistently above 60% is a major step forward for us. But the target is 80%, and I think for all the time we need to keep that in mind. There'll be a level at which will get us de-escalated, but in our minds we're trying to aim for what the actual target is in all these areas. We haven't talked about unscheduled care in great detail. It was mentioned in the previous item. We have a huge programme of work on unscheduled care. We are not happy with the experience that people have, either waiting for ambulances, being in our A&Es, if there's long waits or if they're overcrowded. So it's something that we really do want to work on, and I know as an exec team we're committed to do that. It's hugely complicated and multifactorial, and it's a system issue. So I'm not suggesting this is an easy task, but it's so fundamental to all of our performance, how our unscheduled care system works. So just to point that out. The other thing which sort of links this with the finance item is that we do need to produce an IMTP, as Hugh mentioned earlier in the finance item. We do need to produce that or attempt to produce that later, start to do that later this year, because we need a route map to get back to balance in 3 years' time. That's our conditionally recurrent funding is based on that.
Isn't it?
Well, 2.5 now, yeah, but you're right. So, and part of that will also be dependent on how we approach our performance, because we can't, you know, if we leave a huge gap in our performance, there'll be a huge cost to that from a finance perspective towards the end of the year. So the reason I'm making this point is the importance of balancing out our approach to access and our performance, finance and quality, I suppose, is really evident as we try to produce that IMTP later this year.
Great, okay. To close the item, are the board assured that the right steps are in place to address the items to which we've been alerted to? I think the answer came in the previous item, to be honest, and the work around the clinical groups to make sure that we are both monitoring performance but also taking the right action to address challenges around resourcing or delivery. I think it happens inside that space. It feels to me that it's an opportunity for us to mature our approach to planning across the organisation generally, and also to think through the consequence of the way in which we're delivering. And I'm not absolutely convinced we've done that terribly effectively in the past. It feels as if we're growing a stronger awareness and consciousness around how well we're doing and how we need to be different and what we need to do in the future to ensure that we're delivering optimal services. And I'm hoping, Andrew, we'll see more of that over the next few months as the groups embed, and we can see and we can take more evidence and reassurance from it. Okay, thank you very much for that. Can I suggest we take a 10-minute break?
Okay, so
Diolch yn fawr am dod yn ôl ar amser. Thanks for coming back on time. We're running a few minutes late, so we'll try and stay focused over the next few items. So you'll see we've got a number of items now before we meet for lunch. Improving people and community experience, which I think Sharon's going to take us through next. Equality, Diversity and Inclusion Task Force, which I think Anna and Lisa are going to talk to us about. And then we are going to look at the Refreshing a Healthier Mid and West Wales strategy, which Lee will update us on, and then the Clinical Services Plan, which Lee and Mark will lead in our discussion, and which we've got some colleagues who've joined us at the bottom of the room, which we'll introduce at that time. Great. Okay, so Sharon, can you take us through improving people and community experience?
Lovely. Diolch Cadeirydd. Thank you. So the purpose of the report is just to provide a summary of the feedback from our service users during February and March of this year, and also provides a summary of the year for 24-25. The report also introduces the board to the new People Experience Framework issued by Welsh Government, and this framework is for measuring and reporting on experience, and it brings a new set of metrics together and offers us the ability to benchmark across Wales, which we haven't had previously. As a board, we acknowledge that the feedback received should be used to celebrate and build on what's working well, but also to identify areas where improvements can be made. So from June of this year, the patient experience team will support the clinical care groups to undertake local self-assessments against the framework. And then this will form the baseline for the organisation to create improvement plans to enhance experience that people have when they're using our health board services. As we've previously discussed at board, the triangulation of experience feedback data, along with other metrics, such as outcome metrics, for example, is indicative of our commitment to quality. And the framework will be really helpful, I think, in terms of progressing this work in the future. The report also presents the annual report for the Arts and Health programme for 24-25 for board consideration. It highlights the achievements that have been undertaken throughout the year and the progress made in implementing the Hywel Dda Arts and Health Charter. I'd like to thank our Vice Chair, Eleanor Marks, for her contribution to the development of the report, but also for her continued support of the programme as well. So diolch, Eleanor. And the report also includes some initial feedback from some recent patient experience surveys conducted by the Health Board Managed Practices via the Quality Improvement Framework as part of the General Medical Service Unified Contract. And those are summarised on page 23. Since we've submitted the report, we've had more information in, so we'll include that in the next report to board as well. And the report also references the Health Board pilot in primary care, which started in April of this year, which will run for 3 months with using the Civica system in a selection of practices. So we would hope to bring a preliminary report on that pilot back to board in July also. So I appreciate you will have read the report, but I'm happy to take any questions that you may have. Yeah.
Thank you, Sharon. Colleagues? Yes, please. Chantal.
Thank you, Chair. I just wanted to ask a question around the feedback, because I know that when I was a member of the Listening and Learning Committee, one of the enduring themes that came through was poor communication. And I'm just not sure whether we are just continuing on the same way of dealing with the poor communication, or are we exploring new ways of how we can tackle poor communication?
Thank you, Chantal. I don't know, Mark, if you want to come in after me, because I know you now chair that Listening and Learning Subcommittee. I think the framework, as I described, is probably going to help us in that space, because it really does promote quality improvement methodology in response to the feedback that we're receiving. And we know that as an organisation, we have a lot of expertise in the organisation of quality improvement methodology, and therefore we need to translate that into our day-to-day practice. And I think the clinical care group structure that has recently been introduced as well is another opportunity for not only to conduct the baseline assessment, but also for their integrated governance groups then to actually drill into that Civica data, for example, and pull out any lessons that need to be learned and any improvement that needs to be done. So, and I think you're right, the themes remain fairly consistent. So we need to be looking at that. Yeah.
Thank you. Mark, did you want to add anything?
Yeah, thanks. I think communication is a difficult issue across the National Health Service. My feeling is that we are a lot better communicating than we ever have been. I think we obviously are still somewhat reactive, and we communicate with individuals when something has gone wrong, rather than actually communicating with them during their illness with their families. And I think that there's something we've got to continue to focus on. I'll admit I don't have a straightforward, easy answer to how we do it, apart from it being something that we continually need to discuss. So I think it'll always be something that we need to talk about.
Michael, and then Ewan.
Yeah, well, Chantal kind of slightly stole my thunder, but it was just building on that is it's a very good report, very easy to read, and we got a bit in the report about the headline figures of complaints and breaks it down into appointments and things. So on that point, so if we were looking at something like communication, how does that break down further? Because it doesn't tell us quite under the bonnet as to that, which I think is the point we're making, is that a complaint about communication. So are there different types of communication complaints? I don't know. So it'd be interesting to kind of understand that a little bit without having a report, which is like War and Peace. I appreciate that.
Okay, good point. Can we get more granular understanding when people use that term, or they are concerned about communication? What is it they're actually saying? What is it they're actually thinking? I'll come back to you in a minute. Let's move to Anne and then Ewan.
Thank you, Sharon. Great report. Lovely to read.
Pull the microphone towards you.
My question is, the target set by Welsh Government is 75%. The Health Board performance in this respect has been adversely affected by the increase of case management under early resolution. That seems very sad. Isn't there any way that this should be part of WAG? Because we're actually performing well on early resolution rather than having longer cases, but it's not recognised.
You're observant to note that, Anne. Thank you. I think the report also acknowledges that there's been a 118% increase in the number of early resolution, and that has contributed to the reduction in formal complaints, which as a consequence has adversely affected that 30-day, because the complaints that are now being dealt with are more complex complaints, and therefore that timeline is being stretched. Also, in terms of achieving that early resolution, some of the activities being directed to make sure that we can resolve those issues early and improve that patient experience. So it's a balance, and it has had an impact. So we need to make sure that we can address that in the future so that we maintain that. We'd gone up to 77% compliance. So we need to make sure that we get back up to that compliance going forward.
Great.
Thank you.
Thank you, Anne. Ewan.
Thanks, Chair. And again, just thank you to the team for putting the report together, because that patient voice is always critical. Just a comment really in terms of the Welsh Government People's Experience Framework. Whilst that is really welcomed in terms of giving us some insight into benchmarking data between health boards, a note of caution, because obviously in terms of whilst that's a really useful barometer to kind of look at the difference between Howell Dda and Ira Bevan, Betsy, etc., the logistics and the geographies and the infrastructure between all health boards are very different. So when you're looking at our kind of South Wales cluster of health boards, the proximity principle to healthcare is far easier and shorter compared to someone who may be living in the hinterlands of Ceredigion and having to come down to Prince Philip in terms of care and in terms of clinics. So whilst it's a useful barometer and tool, I wouldn't want us to be unfairly judged in terms of some of those comparators. So it's just a note of caution really in terms of some of that data.
Okay. Sharon, did you want to come back on Michael's point around how can we get under the surface of this term communication to understand really what people are unhappy with.
I think it goes back to Hugh's comment around the microscope and the telescope, and I think we need to do that, but we need to do that in the right forum, and we need to do it with the operational services. But I think what we did at last board was we brought the service into board to give that experience of lessons that have been learned and how we've changed things, and potentially, Michael, periodically, that's something that we can do from the feedback from the listening and learning committee, so that we get into examples of granular details, so that you get that assurance from that perspective as well.
Great, okay. I'm conscious, Michael, I'll come to you now. I'm conscious before we get to that point, just to say within the pack we would have Llys's report from last year, 24-25, which I think, Donna, makes a lot of reference to patient experience in terms of how they receive their experiences. And I think there's so I think terms like communication are qualified partly in the report provided through Llys, because that kind of describes how patients view the way in which they're communicated against. So it does feel to me we can bring perhaps some of these documents together. Michael.
Yeah, thank you, Chair. I'm just reading across two reports. So the Arts and Health annual report update talks about making a public promise through the Charter to integrate arts into the work of the Health Board to improve health and well-being. But I noticed in the previous performance update, it states that we have one therapist, arts therapist, I think, that covers the whole of the Health Board. So I'm just wondering, does that capacity issue pose a wider challenge to that public commitment, or are we assured that the kind of mitigation through the various different art therapy support groups provides sufficient arts therapy support across the region? And I think that question needs to be seen in the kind of wider context of the aspiration for that social model of health.
Yeah, absolutely.
Okay. Yeah, that's really helpful. I mean, our arts and health team has grown slightly, and the focus of the work of this team is specifically around service users and patients who are within our facilities. There's also the arts in terms of the psychological well-being for staff as well. So it's how we bring those together to make sure that our people benefit from this. Yeah.
Great. Okay. A really good point, and it is part of, it does sit neatly within our social model of health and what we should be and how actually we work with communities, because there's a tremendous amount of art within communities generally. How much are we connecting with those communities, or working co-productively or collaboratively, seems to me is a key question. Adriana, you're going to come back on this point?
Yes. That's all right. Just briefly, as you mentioned, the social model for health, and it's a good point, Michael, but there is a distinction between arts and health as an intervention to recover and then improve health, and there is a difference on the social model for health using, as the Chair, thank you, is pointing, what capacities, faculties, resources there are in communities to enable people to stay healthy. But we are trying to incorporate, and we had this very discussion at our Quality and Safety Committee just a few days ago when, as Lisa mentioned, some of the interventions for our workforce with interventions that work in nature, but how do we broaden that and how do we make all of these a little bit more upstream, that the communities have those connections and enable themselves to help individuals in our principles to stay healthy.
Great. Eleanor, and then I'm going to come to Phil, and I'm going to close the item.
Thank you. And I should say I chair the Arts and Health Group. Excuse me. It's a small team, but they are running lots of projects across the Health Board. And the model is that we are trying to mainstream that, bringing other people, clinical leads and leaders in the organisation into the updates for that so that they are aware of what's happening. I've been to a few of these events, they're fabulous. I've been to one with storytelling with people with dementia in Glangwili. I'm going to see the singing in ITU in Withy Bush next week. I went to a session in Prince Philip. It's small, but it's really important and growing, and they are doing evaluation of it, which I think will help show the positive impact it makes. And if we can mainstream that more and link it more with the social model of health and with the Recovery in Nature programme, it starts to become a conversation that is more mainstreamed than separately arts in health.
Thank you, Eleanor. Very helpful. Phil.
Yeah, just thank you, Chair. Just reflecting on the communication point, I think we've come a long way from the past, as Mark was inferring, where a lot of care was probably about, well, deliver the care, and then communication was a bit of an optional extra. So I think we've moved a long way from that kind of approach. However, it's clear that we've got a long way to go, and we need to be curious about how people experience our care. I think even more than we are now. There are some health delivery areas where communication issues show themselves more than others. I think our waiting list, that's a point where people do have concerns about communication, and of course we've put the waiting list support service in place for that. So I think there are things that we've done in response to communication issues. I think we need to continue to test whether that service is giving that communication that our public is looking for. I think also in our A&Es, I think that's another area where we do see concerns about communication, and there's all sorts of reasons. As staff, we know that they're a crowded area, and we know that staff really struggle at times overwhelmed. But that's an area through the unscheduled care programme that we discussed earlier in board, where we're not just focused on sort of flow and access, we're also, the third piece of that work is around the environment, and part of the environment is the way people are communicated with. And so we're looking at ways of how we support communication within our A&Es, because we know that's a particular issue. So just thinking about Michael's point of, where can we get under the bonnet of some of that, the kind of bulk of the communication issues, I think there are ways of doing that, perhaps even by looking at different service areas, might even be just a start, and what we're doing to try and address those issues.
Great. My final comment before we move on is that I think we need to be able to correlate patient personas with the data as well. So if you are non-white, or you are over 70, or you are 15, or you have some level of disability, or you are a first Welsh language speaker, what does that mean in terms of the way in which you experience services, and how does your complaint manifest? And I'm not sure yet we've got the data that allows us to cross-reference those kinds of considerations, because that would tell us an enormous amount about how people are communicated with, as opposed to just, it focuses less on us as a communicating device and more about what's the patient experience or the way in which we treat them.
Thank you, Chair. I was reading the patient experience framework, and within the core data set, those areas like gender, age, language, etc., were included as part of that core data set. So we should have that information going forward. We just need to make sure that we get that analytical lens over it then, so we can pull that out in our reports going forward.
Great. So can I suggest that would come back to Quality and Safety Experience Committee? Can I suggest that it's kind of picked up in there? We look at a bit more granular detail around the respondent community. Great. Okay. Very helpful. So just in terms of the recommendations, we've obviously received and discussed the patient experience report, and well done to the team, because I think there's good progress here. And clearly, a lot of people are very satisfied with our service, but we need not to take our eye off the ball in terms of those who are not, or are not receiving a good service. And then secondly, to receive the People's Experience Framework and revised People's Experience, which I think is and the planned self-assessment, which will begin from next month, and then receive and approve the Arts and Health Annual Report 24-25, noting Michael's comments and how we need to ensure that this is woven into our social model of health, and we are building the service as best as possible. Great, okay, thank you for that. Can I move us on to Equality, Diversity and Inclusion Task Force? Anna, Lisa, I don't know who wants to open up.
Diolch, Gareth. So we have the update report from the early months of the new EDI task force, and we've kept it succinct, and I recognise that it is somewhat dry, and I think that reflects the fact that we are doing a lot of work behind the scenes to set the foundations for a really good and significant initiative for this organisation that we hope will provide the platform for some very substantial improvement in our performance on this agenda, and I appreciate there'll be an appetite for more, and I'm hoping that by the autumn we'll be able to come back with some more specific details. So to that end, a second workshop is happening in a few weeks' time, where our priority is two key priorities. One is to make concrete our initial set of actions, and we've got already quite a list of things that we think are potentially achievable to start quite quickly. And the second, and really importantly, is to consider how we can engage our organisation in this work. I think I have said too many times already that inclusion is in the title, and therefore we need an inclusive process. I'm absolutely determined this is not going to be yet another corporate initiative which we flog from the centre but really makes no sustainable change on the ground. So in that vein, I don't want to miss this opportunity really to take to make really a call to action for every single board member around this table to really think about what this agenda means in our personal leadership in this organisation. I work with a Ned in another part of the UK who he's adamant in his view that unless a board is talking for half of its time about inequities and how they show up in healthcare and in employment, it's a board that's not doing its job properly. So we know that these inequities and inequalities show up in every aspect of our work as an employer, as a provider of healthcare. It's unacceptable, we need to act, and it's every person's responsibility to play their part in that process. So when you're on the receiving end of requests for contribution to this work, please don't stick it in a pile with a load of other things. I know everybody's really busy, but we have got to get an organisation-wide momentum around this work. It will not be achieved through Lisa's team, through my efforts, through the chair's efforts, through any single one of us. It needs to be all of us bringing collective leadership to this agenda. So please can I ask for that? And actually I would encourage, Chair, for the board to think not simply about supporting the work of the task force as is put in this recommendation, but actually committing to an individual and collective leadership of material change in our organisation.
Thank you, Anna. Lisa, would you add anything to that?
I suppose the only level of detail to add to it is part of the work that we will be doing in preparation for that workshop is collecting all of the things that we know are happening already within the organisation to see what can be scaled up faster. And also we will be feeding the lens of the staff survey through that group as well when we take the cut of information based upon the protected characteristics.
Very good. Colleagues, questions or observations?
Chair, I welcome Anna's comment about all of us. All of us should be dealing with it or should take responsibility for it, and in particular, but it's just a plea from me that we don't just focus on compliance, that we look at it both through the lens of compliance as well as the culture of the organisation.
I completely agree with that. It's a step beyond just compliance. Okay, I'm not sure whether I should be worried that nobody's responded or pleased. Adiana.
Thank you, Chair, and thank you, Anna. I did think about it with a comment, but I think it is important to comment because you did emphasize the equity, and we've had previous discussions, and the report and the task force is in the equality and duty. And you also stated in your very powerful note just now, Anna, about our duty to the health of our population, equity. So my point is that equality duty is a duty, and it's a moral obligation to all of our protected characteristics, as the chair mentions. However, a much bigger issue for our population's health is the equity, and which is not necessarily under the protected characteristics, which is the socioeconomic deprivation. And I'll just say that we have in 2 out of 3 of our countries, every 3rd child living in a relative poverty. And that is the work that we're trying all through our services, but also trying to, in this year's annual plan and going forward, to embed much more clearly and much more strongly with trying to improve the population's health with a model that we're trying to do with equity and prevention. Thank you.
Thank you, Diana. So the thing I would say is you'll know that the reason why we established this task force was because there was a burning platform beneath this. That burning platform was that we were starting to look at some data which was clearly indicating the fact that we're not as inclusive as we would like to think we are, and that there's evidence of mistreatment and discrimination taking place inside the organisation. And the first rule of understanding equality is you own it. You own your privilege, you own your responsibility for putting these things right, and you're transparent and open in that, even if it's uncomfortable and difficult to embrace and manage. And I'm not sure the organisation has got to that point in being able to recognise these things. I think we need to do a lot more work inside this space, and in truth, we need to kind of move faster and, in my view, a bit quicker. I'm a bit frustrated because I feel as if it's taken us quite a lot of time to even get to this point. And actually, it is something that we need to work harder to deliver more quickly. It feels as if it's not really a priority. We have a small group of very committed individuals trying desperately to take this forward, but largely the organisation is not that consumed or concerned about some of these issues as we understand them. And yet it sits at the very heart of what we do. Everything we do, I would argue that at least 15 or 20% of our work is associated with the consequence of people not being treated equally in our society, not being able to access the right services, whether they're deprived through their socioeconomic status or their age or their ethnicity, their gender, their disability, their sexuality. The consequence of mistreatments and injustice in those areas results in an enormous health inequality for everybody, and we have to deal with that this far down the system. So there's a rationale for us wanting to engage in this work more across these 3 counties, because it makes a difference to the way in which we deliver our services and the demand that's placed on our services. So even if sometimes people are uncomfortable with the morality behind some of this work, the business case is profound for why we need to just improve equality across our communities and reduce the consequence of disadvantage. Anna's call to everybody to take a more proactive role is well meant, and I would amplify that. I think we absolutely need to be able to be central to the way in which we think about these issues and not see ourselves as sat on the sideline observing what we think is taking place. We need to get into the mix of this and understand what these things mean. I recently read a book. It's about the science of racism. And frankly, I thought I knew everything about racism, which is an arrogant white male perspective. But having worked in a whole series of environments over the last few years, I kind of felt my knowledge was probably a bit more advanced than others. And the book has humbled me. It has humbled me when I think about the fact I live in a society of advantage, specifically for white communities. It is humbling and it's uncomfortable just to read this, and somehow reminding ourselves regularly of the fact we do not live in an equal society. people are not treated fairly. Some people are privileged over others because of characteristics that are beyond their scope, or disadvantaged because of their characteristics. We just have to deal with these things. They make for an unsustainable society, an unsustainable community, and an unsustainable organisation, unless we can manage these things, take them to heart, and do something about them. So I'd actually emphasise what Anna said. I want all of us to take more of a key involvement in these activities as they take place, and to find ways in which we can impact positively upon this organisation in terms of articulating our passion and our compassion for issues of equality and diversity. Okay. Thank you for that. That's very helpful. Call upon our services or support if you need them as we move forward. Let's move to refreshing the Healthier Mid and West Wales strategy. Lee.
Thank you, Chair. So this is the latest in a series of papers in relation to the refresh of the strategy. This paper is proposing an approach to the strategy refresh with the aim of producing a refreshed version of the Healthier Mid and West Wales by January 2026. This is a rapid process that we're going through to get to that point, but I think that's important given the question around the strategic void that you mentioned earlier, Chair, but also it will allow us then to, it will also support the development of plans heading into next financial year. So it's quite important that we work to a tight timetable like that. A review of the strategy has already been undertaken, as is noted in the paper, and a summary of the findings provided within the report. That gives us a sense of the chapters within the document of the previous Healthy Mid West Wales strategy and what we may want to reflect on through the coming months. We think it'll be important as part of this process for us as a board, to set out the design principles we wish to consider within that refresh strategy. So we set some parameters around it, and what we're proposing within the paper is that we use a board seminar to consider that if members are in agreement with that. We do have significant public consultation anticipated over the coming months, as everyone knows. The CSP consultation in particular will help feed into this refresh, but we are conscious of public engagement fatigue also. So what we're proposing is using a continuous engagement approach, and we're going to utilise the engagement headquarters platform that we already have to support that. In the first instance, we're asking members of the public one simple question to help us with that. We don't want to make it too complex or have too much variance. So what we're asking at this stage is, or what we're proposing to ask is, what is important for you to live a healthy life? So we're really focused on that question about living a healthy life, linked to our revised mission statement, but also the point that we've just considered now in relation to equality within healthy lives. The second half of the paper provides a bit of a deep dive into the urgent emergency care position. One of our clinical leads, Karen Brown, was intending to come today to discuss this, but unfortunately, last minute is unable to make it. But I think the section of the report identifies some of the key considerations for us within the strategic refresh relating to urgent emergency care and the current thinking on potential future model. I think the key points for board are, firstly, we need to be clear and honest with our public and ourselves that the current system is under substantial pressure, as we've noted in previous papers, and the patient and staff experiences far below what we would like to see, and certainly far below what it was pre-COVID. So to respond to that adequately, we are going to need to see a paradigm shift in the urgent emergency care model. It needs to be considerably different, with the aspiration that services can be delivered in a timely way, in the right place, and to the highest quality. This will require, as I mentioned previously, a shift in our model, so a shift towards the left-hand side of our model design, if you like, to support people in their communities, but also to embrace technology and digital opportunities to change that that delivery mechanism. The level of change we are expecting in order to get back to the standards we would aspire to, we believe is going to need us to be quite radical in this space, and I know Karen would talk about that if she was here, and I'd suggest we probably do that in a future board seminar. And to get to that point, we're going to need to empower our clinical teams to really think about what that new model might look like, and to work in partnership with our communities to deliver a model that works for individuals as well as provides a better service at a system level. So I will stop at that point, Chair, and questions.
Okay, great. Thank you, Lee. Colleagues, questions or observations? Eleanor.
Diolch, Cadeirydd. I think this is a really great paper. When I first joined the board, I'd read this strategy and its principles stand up still for me. Our context has changed enormously, and I think that's really important to recognise. And we need to have more proactive conversations with our communities about what they want and what people want in those communities and how we deliver. And I think that's a really important part of it. The principles of care near a home, the principles of, you know, getting the right care at the right time in the right place, all still really matter. There's an enormous read across to the CSP, which is a future item. We've spoken in the past about the likelihood or otherwise of a new hospital. We are looking at different integrated models. I think all of that frames this now in a way that we need to take it forward for the next 5-10 years. And I found this really helpful to start reframing that. It was more of a download than a question, really. Thank you, Chair.
Thank you, Eleanor. Michael. Ewan.
Yeah, I echo what the Vice Chair says in that respect. And building on that, it's that overlap with the CSP is interesting, speaking as a lawyer who's done lots of consultations issues, because clearly the question you're asking here, which I think is a good question, is the kind of question that might come up in a CSP group meeting.
Yep.
So I was going to ask you, Lee, about capturing the CSP feedback into this, and you get ahead of me on that, so well done. But I really think that's absolutely vital, and we need to make sure that we're not going down to kind of silos, if you see what I mean, on this kind of thing. I'm sure we're not, but that's really important, because what we get back in this, if we go ahead with CSP, what comes back in that is going to be absolutely spot on for some of this as well, surely, isn't it? So that's a big challenge, but I think that's really important.
There is, you're absolutely right, there's a connection between the broadest, which is slightly my concern, which is that people quite rightly doing the clinical services plan, and I'm going to bleed into that now, can say, well, where's the strategic direction here? You know, what is it you're trying to do? And it should sit very comfortably within the existing strategy, but what we're planning in the future for the healthier Mid and West Wales. It should all be linked into that so that people can see our motivations are about delivering a happier and healthier Mid and West Wales in the long term. You're right, Michael. There needs to be a connection there. Ewan.
Thanks, Chair. And again, thanks for the report, Lee. It's good to see in terms of the kind of urgency now in terms of working towards a refresh for bringing back here, hopefully in January next year, and then obviously for March. Welcome in terms of on page 4, particularly now around the working in partnership, where it clearly articulates to work with the voluntary third and private sectors within our communities, and echoing what the Vice Chair was saying, the solutions to what we will require to have a robust new plan lies with our communities. It's not for us to dictate to them what we are going to provide to them. It's for them to dictate to us what we are there to provide to them on their behalf. The only kind of concern I would perhaps flag up is, whilst the use of a continuous dialogue via electronic means, Engagement HQ is welcome for those, the majority perhaps of our population who would really want to articulate their concerns do not utilise electronic means on a routine basis or have the means to do it themselves. So I think perhaps, again, thinking smarter in terms of how we utilise our communities and the existing mechanisms such as the community hubs. I mean, we're sitting literally half a mile from the Carmarthenshire Living Well Centre, who have 300 to 400 people going through the doors a week, who would be a really good barometer in terms of getting that opinion in terms of what services they require and how we can service them better. And I know that's a similar case in terms of the hub in Lampeter and also what they're looking at in Neyland and the community hub there as well in Pembrokeshire. So I think it's a great kind of, step forward in terms of the time scales, because I know you said, Chair, in the previous item, we need to work harder to deliver more quality and quickly. And I think, the Middle West Wales strategy, as we've heard, the previous document was very much pre-COVID in terms of its alliteration and focus. What we're looking at now is a very different set of community circumstances. I think we need to catch up very quickly to retain the confidence of our communities, and we're all here to kind of work to achieve that collectively.
Well said. I note what you said, Lee, which is that we're currently about to embark on an engagement, a consultation around the clinical services plan. We are currently in the middle of our consultation around the MRU. There are other consultations that we're engaged in. We might not be lead party, but we are part of other consultations taking place. I don't think it's a matter of creating consultation fatigue. I think it's more about what avenue we choose or how we choose to engage with the wider population. So back to your point, Ewan, using hubs and asking single questions seems to me to be very different from what we might be doing when we're out talking to people about the clinical services plan. I don't think people will necessarily become fatigued by that, because we are talking to very different communities. There's 385,000 people across these counties for us to talk to. We'll never be able to talk enough or have the opportunity to do that. It's about talking to people in the right way. I do wonder whether, and I thought your question is great. I think it's a really good question. I would even simplify that further and just say what makes you healthy and happy. As opposed to what's determining that, what makes you healthy and happy, because that's exactly what we want. And from that, we will find all kinds of data. But I do wonder about whether we've talked about using SenseMaker as a device to capture story, and whether there's a possibility of us capturing stories through the hub about people's experience of living happy and healthy lives, and how much health is significant in terms of those decisions they make about how they want to live their lives. I know you want to come back in. Anna, did you want to come in?
Just a really quick comment, but I did want to add the voice of the Quality, Safety and Experience Committee to Lee's point around urgent and emergency care. Through our committee, we regularly consider the urgent and emergency care pathways from a number of different angles, and in recent times, of course, we've had the GERFT report, and I think the committee has been unambiguous in concluding that there is not a solution that we aspire to deliver that can be achieved by tweaking around the edges of what we currently have, and that to try to achieve that through constant toing and froing with improvement plans and so on is a fool's errand, really. And so the committee was absolutely clear at that point that we need to take this opportunity to say, we're going to have to think very differently about this, and we can't put off this decision any longer, because the consequence of doing so is we continue to fail our populations in what might otherwise be achieved in their health and well-being.
Well said. Very good. Alwena, did you want to come in before I come back to Lee?
Thank you. Just to provide some reassurance, in a sense, that whilst we see Engagement HQ as a digital platform that will enable us to capture some of the information, it's not the only way that we will be listening to our communities. And we do have already a network through, for example, the Community Outreach Development Team, who work with various groups and talk on a regular basis. We will have presence at things like the Pembrokeshire Show, where we can have those conversations. And it may be that it's not the individual that feeds in their response, but an advocate on their behalf, be that a colleague in the team or somebody, absolutely taking on board Iwan's points around the community hubs. How can we enable people to speak on behalf of others and capture some of that information? And just to note that just this week, for the Prince Philip MIU, we've had some great conversations with people who are sat in the waiting room, waiting to access the service. And how do we have that question with our service users who are sat there waiting for treatment? How do we enable that conversation so we can weave it in that way as well? But absolutely open to different ways of thinking and ideas. So.
Very good. Thank you. Thank you for that reassurance. Lee.
Yeah, so I think to pick up on the points, I think everyone's in complete agreement really on that. So to pick up on Michael's point initially, so the clinical services plan is effectively a sub-programme of the overall strategic direction, isn't it? So there's naturally a lot of read across between them. I think what's quite important in the way we construct the type of question we ask is we want to make sure that a lot of the time when we have conversations with our public, it's quite focused on what service is provided where. So that's the nature of the conversation we'll have with our public in relation to the CSP. But that will naturally expand into then a bigger question about what fundamentally, what's more important about supporting people to live healthy and independent lives. So we wanted to make sure that question is kind of standing on strong really in this process, so that we really focus in people on that type of reflection. So we will use the CSP events to have lots of conversations, and that will allow us to feed in some of that thinking. But alongside that, it's really important that we take all the opportunities that Ewan was describing and you were describing, Chair, to just have much broader conversations. You know, we talk about every contact counts and so on. We can try to embed that into the thousands of patient contacts we have every day, the thousands of public contacts we have every day, and see how much we can draw from those in answering this seemingly simple question. So I guess what we're trying to explain through this is it's less about having staged public events where people come in and talk to us about a topic. It's more about how we get those conversations, as Ewan and others are describing, where we encourage all members of staff as well, actually, to have that conversation, ask that question, and then feed it back into the sort of free the platform that we've got to collate all that information, and that will help inform us over the coming months. So, just to by way of get additional thinking on it, what we're intending is the first phase will be very much focused on this quite simple question, and then later we'll start to ask more targeted questions then about, you know, what does that mean in relation to, say, our digital strategy or our social model for health plans and primary community care and so on, so we get into levels of detail beyond that simple question.
Great, thank you very much, Lee. I'm going to pull the item to a close. So, are we happy to endorse the methodology that's been outlined in the paper? I think it's robust. It's a good methodology, and can we take assurance from the learning to date on what's happened? Yep, great. Note the engagement methodology. Thank you, Alwana, for the reassurance. It'll be broader than just the platform. And that's not saying the platform isn't a really good idea. I think it is. But I think it's an opportunity for us to explore all avenues around this. And the simplicity of the question, I think, is fantastic. I think that's a really great way to move forward. So approve the launch of Have Your Say, the website. We haven't really discussed the emergent thinking on the urgent and emergency care. I'm conscious Karen and Peter are not with us to be able to share their views on that. Having said that, I don't think we've had time, or we have time at this point to do it. I also think there's a couple of swim lanes on this. So ultimately, we would want, according to our annual plan, to have things in place regarding urgent and emergency care within the context of this year. So we need to move at pace in terms of thinking about urgency and emergency care services, whereas actually we will only get to the stage of next January having something hard and fast in the strategic space that we can look at. So I would think there would be some value coming back to the next board with a deeper kind of look at urgency, emergency care and emerging plans and what we think we will be doing as we move forward from here for board discussion and approval. Is everybody comfortable with that? I think that would be, I'm looking at Andrew and Lee, because I know you'll probably be instrumental in being able to take that forward. Oh, and of course the boss.
Well, Can I just start, and then Andrew might want to give some details. Is that okay, Chair? Chair, I suppose with the unscheduled care programme, some of it, there's a huge amount of it that we need to deliver this year around emergency urgent care. So it isn't, there's quite a lot of the work that isn't so much about bringing work for approval. It would be more about describing how we're approaching this year's piece of work. However, mindful of Anna's point that to really make the step change, there may be some transformational changes that would require approval that we might have to plan in future years. So I wouldn't, it's not quite as, I wouldn't want to give the impression that all of it requires some sort of big consultation.
No, my interest is not in, frankly, not approving it, but offering the endorsement of this board for that programme of work to strengthen individuals who need to be able to take that forward and then deal with some of the consequences inside, you know, in the delivery of it.
Which I think would be really helpful, partly because it's an enormous piece of work. It requires reprioritisation of people's time, if nothing else. So to have the board's endorsement of the importance of it, I think would be helpful.
Andrew?
Yeah, no, I completely agree with that. And I think the other key aspect of that is we are planning a workshop on the 23rd of June, so that'll be before the next board meeting on a regional basis to explore some of the more transformational, or the art of the possible in the more transformational space if we worked with our Welsh Ambulance partners and Swansea Bay. So that might be a good moment in July to bring a bit of an update in terms of what we're trying to progress urgently this year that fits with a more radical approach to addressing some of the service challenges we've got, as well as a bit of a connection into some of the more strategic regional conversation as well.
Great. Okay. Well, let's plan on bringing back to in July that paper. And I agree with you. It's not for approval. It's for endorsement and for anything we can do to support as a board the work that's taking place in this area. Thank you. Thank you for that. That's all very. Thank you, Lee, for the work that's gone into that and your team. I know it's taken a great deal of time and effort, and it's articulated and it's clear in the paper and what you're planning. Let's move to clinical services plan. Lee and Mark, I think you are probably going to kick off this conversation to begin with.
Yeah. I'll start. Thank you, Chair, and then I'll hand over to Mark. Mark will take us through most of the information, but I'll just start with a few words of context firstly. So I think everyone around the table will know that we've been quite clear as a board for a number of years that our service models are unsustainable, and in 2023 we agreed as a board to establish a programme to look at 9 services in particular, and Mark will cover those services shortly. Just by way of an explanation of the process we've gone through. So we spent nearly 12 months undertaking a very detailed process of collating information on those services, both qualitative and quantitative, and that included nearly 6,000 survey responses from service users. Then in phase 2 of the programme, we formed an options development group which consisted of around 80 clinical leads and senior operational managers, including a spread across the 9 services and other stakeholders from in and outside of the organisation. We tasked that group with coming up with a set of options, and they did that in April, so pretty quickly after the board agreed that in March. That was then tested through check and challenge sessions with a very broad group of staff within the organisations and some members of the public also. Further refinement and assessment of those options was undertaken through last summer, leading to the output report which came to board in November. Board at that point supported the programme to progress to the 3rd phase, which is public consultation. So the preparatory work for that consultation has now concluded, and the proposal is the board support the launch of that consultation today. So just finally, I guess for me, clearly a great deal of work has been undertaken to date on this, and I'd just like to convey my thanks again to everyone who's been part of that. I would like to stress, though, that we are clear that no decision has been made at this point, and what we want to achieve through this consultation process is to hear the widest range of ideas, concerns, and indeed alternative options that may come through the process. So we're very open and receptive to having that conversation with our staff and our public, and we're looking forward to the next month to really help us with that process.
Before you come in, Mark, just to welcome Dr. Senthil Kumar and Irie, who's a regular at the board, to join this conversation as well. Great.
Yeah, great. Diolch, thank you very much. So just a bit of, you've introduced Senthil and Irie, but Senthil is our clinical lead for stroke for the Health Board and chaired the task and finish group looking at stroke services. Irie is the Deputy Medical Director for Acute Services and has been involved in the whole of the programme and is also the chair of our clinical reference group during the process as well. I likely want to thank all of our staff, public and stakeholders who've supported us to get to this stage today, and also thank all of our staff who've worked incredibly hard. I can't tell you how much work it's taken to get to this point. We do have a strategy, as we've discussed, a healthy Mid and West Wales. However, the board has recognised that we have really significant service fragilities, and we've really struggled to get to pre-pandemic levels of activity. And as a result, we, the board, agreed that we needed to address these issues, and this has led to the development of clinical services plan. Our main drivers for change are difficulties in staffing across our multiple sites, our poor estate, and the inability of these challenges, therefore, to return to pre-pandemic levels of activity. And basically, we believe we're not delivering the highest standards of care to our patients. In March 2023, the board decided that we would focus on 9 clinical service areas. Critical care, and this is because of service fragilities, particularly at Prince Philip Hospital. Emergency general surgery, because of service fragilities, particularly at Withybush Hospital. Stroke services, because of service fragilities across the whole of the Health Board, and an inability of us to be able to meet standards with our current configuration. We decided to look to planned care services, dermatology, elective orthopedics, ophthalmology, and urology. This was because of our inability to reach pre-pandemic levels of activity, and the same for diagnostic services, endoscopy, and radiology. We have 2 other services that also we've been working on over the last few years, and one more recently, urgent and emergency pediatrics, which we previously consulted on, and primary and community services that, as we've heard, we're working through at the moment. Board has approved the CSB consultation plan, and in January this year, I was very pleased to be asked. What I'd like to do today is to ask the board to endorse enabling the launch of our public consultation, which will go live today if we, as a board, endorse that. And that will be for a period of 3 months until the 31st of August. We wish to consult on the 9 services that I've described, as well as the potential future roles of our hospitals. And that leads in, I think, as we've discussed, a broader discussion with our public. We've developed the consultation documents, and many of you will see those in front of you today, and the questionnaires, and also we have a detailed plan for the consultation process. The questionnaires will be available online today via our dedicated webpage, should we decide to proceed, and they can also, members of the public can also request hard copies. We are going to be holding quite a number of engagement events, and I would very much like to encourage as many people as possible to come and speak to us at our events across the Health Board. We will detail these again on the Health Board website. We need people's views on which of the options everyone think are best to able to address the service fragilities, to improve the standards of care or reduce waiting times. Individuals can tell us concerns they have about the options that we have described and the impacts they think they have, as well as their thoughts on the future roles of the hospitals. They can tell us if there's anything they think we need to consider, or importantly, to suggest alternative options or ideas. The options we describe are the options we have come up with, and they are not predetermined. We very much want to hear the options from our public. During the process, we've updated and refined our impact assessments, We've undertaken health impact assessments, equality impact assessments, and regional impact assessments. Should we decide to proceed, we will be undertaking a midpoint review where we will consider feedback to date and identify gaps in any responses. We describe in the paper the consultation quality assurance process, which has been undertaken by Hugh Irwin & Co., following the enhanced consultation framework from the Centre of Consultation. And Hugh Irwin & Co. have confirmed we've completed stage 1 of the process, which is the pre-consultation phase, building the foundations. In the paper, we also wish to share an update on urgent and emergency paediatrics implementation at Withybush Hospital. We developed a revised set of room plans and costings to meet the Puffin Ward area clinical template, and these are being aligned with the future service requirements and capital funding availability. So thank you, Chair. I'd very much like us to take some questions and have a discussion about the clinical services plan.
Colleagues at the back, would you like to add anything?
Yeah, so I'd like to apologise for my voice because I've lost it a bit like Ellen. But thank you, yeah. Diolch, Deirydd. I think clinicians in Hywel Dda are anxious for progress and for change, as Anna has pointed out. We know that our services are under extreme pressures. We're not delivering on the performance that we know we want to and we can, and so we're very, very keen to move forward with the refresh of the Healthier Mid and West Wales strategy and the fragile services which have been identified as part of the clinical services plan. So as a group of clinicians and service and stakeholders, as well as I assume the stakeholders from the communities, we're very keen to progress with this. We've understood for a long time that many of our services are very fragile, they're not sustainable, and urgent change is desperately needed. I welcome the opportunity for us all to get out, speak to our communities, discuss what is important to them, and for us to explain how things can be better and how our vision can affect the services moving forward. So I welcome this decision to go out to the public and consult on the CSP.
Fantastic. Senthil, would you like to add anything?
Thank you, Chair, for having me here today. I think Lee and Mark have pretty much covered everything what I would like to say. For stroke, I'm here as a lead for stroke, and it couldn't have happened at a better time, the CSP. Stroke was getting to a stage, the way the provision of services across 4 sites were getting to a stage, we had to do something about it. And the standards are constantly improving. The stroke as a specialty has evolved in the last 10 years significantly. And for us to keep up pace with these improving changes and to be nationally strategically aligned, we had to do something. And I was so glad and heartened that the Health Board was watching this and it happened at the right time. We have the biggest issue in this Health Board with geography. I don't want to go into those kind of details, but I just want to simply say I fully endorse what Lee and Mark had said, and from the clinician's perspective, this is something which had to happen. Thank you very much.
Thank you very much, Senthil. Thank you, colleagues. Open for questions. Chantal?
Thank you, Chair. I think when I read the document, I would say that there is a rationale for the clinical services plan in the consultation. It's just a plea in terms of the language that we're using within the consultation document. Because when I'm looking at it from the perspective of the user, they would be coming from a different perspective. And does the consultation document give them that flavour that their views, their concerns in light of the geographical realities of the community we serve? I'm not so sure about that. So it's just a question of whether we need to give a little bit more information around how we're going to achieve what we're proposing, depending on what the users want, of course. But for me, it was that lack of detail around how the user will perceive it and whether they will be reassured by the steps that we're undertaking in order to make the changes occur.
Okay, very helpful. I'm going to come to Alwena in a minute. We'll take a few more questions first, Alwena, before Michael.
Yeah, I feel I'm going to double act with Chantel here, but I just want to build again on something she just said there on language point. I think, speaking as the lawyer in the room, to a certain extent, you are kind of constrained by language you have to use in a proper consultation. So use of the words like consultation and engagement, or you've got to use those words. But I think what we need to kind of, I think, get a flavour of is that it's not just a consultation. I would like to think that it's a kind of a co-production, co-design with our communities. As was said, everything's on the table here, and we want the communities and the staff and everybody to be as essential architect of what's going to happen as anybody else. So that's, I think, the trouble is, that's again, but as I say, Alwena is slightly constrained by statutory language, but I would hope that we would make that emphasis really at the forefront of any communications from this day on with our public and our staff and everybody, all our stakeholders.
Absolutely. We'll come back to that, but absolutely.
Thank you very much. It's the staff. We've got a lovely consultation list of events in the future coming up for the public. Is there going to be a list of events for the staff? The staff are our users. They supply the service. They are part of the service, and they can present the service to our public better than any of us can. So they need to be strongly on board.
Good point. We'll come back. So we'll leave that question there, because if you come back to that, that would be great. Eleanor.
Diolch, Cadeirydd.
Eiri, do you want to come back in?
Do you want to go first?
Oh, sorry. Yes, I was just going to say that the options that have been developed are suggestions. They're a framework to work with, not predetermined outcomes. So I think it's just the start of a process, isn't it? So the public and the staff and everybody needs to now come and tell us what their opinions are, what's important to them, and they'll all go into the mix to be understood. So the options aren't predetermined decisions. I just wanted to emphasize.
Okay. Sorry, Eleanor.
No, that's fine. Thank you. And thank you to Chantal, Nairi and Mark. What impresses me about this is it's clinically thought through, clinically led, and I hear the desperation from the clinicians to actually get a move on and get something done. I think that's absolutely right. I will add to other points. I think it needs, in the communication, to link much more to the Mid and West Wales strategic plan. I think that's really important. I think Anne's point around the staff, they are our advocates, you're our advocates, we are. Alongside this somewhere, we need a plain Welsh, plain English conversation with people about what it means for them. I think for our staff, they will understand this. It's clinically driven, it's sensible, it's practical. Drawing other people in to help design with our staff what the future looks like is really important, because there are some very important public conversations we need to have. What do you want? What do you need? We can explain why a service isn't particularly working well. We can talk about our geography, but we also need a conversation about it. What is it that you need near home? There's a what do you want, what do you need kind of conversation. And I think a proactive, early conversation before changes is really important. So we almost need not two versions, but somehow to entertain that plain Welsh, plain English conversation, words that mean something to the public. If I hadn't been sitting on the board for 18 months or so now, I would read this and go, I can see they want it. What does it mean for me? And I think that's a really important question we need to address. It's important on both sides, I think. We know as a board, as clinicians and others, we can't continue without having those conversations.
I completely agree with that. And I suspect if we've hit the right mark, and we're going to come to our runner now, because I know she'll probably be frustrated we're having this conversation and not drawing on her wisdom. I suspect if we haven't had a robust, kind of contentious, debatable, interesting, rich conversation with the public, we've not done our job well enough in terms of our consultation. We have just not. We have to allow those things to surface in our conversations. Alban, I'm going to come to you, and then I'm going to come to Lisa, and I'll then come to Bwrdd.
Thank you, diolch Cadeirydd. If I could go through the various points in turn, if that's okay. Where it comes to a lack of detail in the what's in it for me, maybe, question, I'm conscious that board members have two documents on the table with them, that are the full consultation document and the summary consultation document. What isn't there, because they are coming hot off the press at the moment, is the rest of the documentation that comes with it. So that includes a easy read version in both Welsh and English. So that's to support members of our community that may have additional needs, but it spells things out in very, very simple language and with pictures around what does this mean for us. That's also supplemented by a youth version, which we actually used yesterday to explain to colleagues around what are the options and how they compare, and they are all the options on a single page in very simple language, available in Welsh and English. We also have audio versions, BSL versions, versions in Arabic, Ukrainian, Russian and Polish, so that we can tap into the other languages that are most common in our communities. We also have Taylor Jones stories. So they look at, if I am Alan, who lives in Llanelli, who has a particular condition, what does it mean to me if I need to access these services going forward under the different options? So we've tried to take our imaginary family and try and walk people through so that you can do that what's in it for me perspective. We also have case studies around each of the services, which we will use during the consultation event. So I hope that provides some reassurance around the whole suite of documentation that's available. But as I say, we are hitting the presses on this, but they will be available electronically if board gives us the go-ahead this afternoon. So those are some of the elements. When it comes to co-design with our communities and being part of the process, absolutely. Right at the start of this, we received 6,000 questionnaire responses from service users from across our patch. Now, does that mean that they've co-produced? Not necessarily, but they've had a voice, and we also had members of our communities part of the options development process alongside our staff. So there has been an element of trying to build this with our communities. Can we do more? Can we do different? Absolutely. But there's the complexity that these are 9 services that we're running at the same time. So we are a little bit constrained by what can we keep safe from a consultation legislation perspective and what can we do from a co-production and co-design perspective. When it comes to the staff events, absolutely. We've got staff events preceding all the public events, and they are across our sites. And again, staff have been involved in the development of the options with us. We have been using any opportunity that we can through our staff calls during the past year to provide updates as we go. We recognise that not everybody attends, but the recordings are available, and we've been communicating with our staff. But we'd really value the support of trade unions in having those conversations when we go out to the canteens, when we go on walk-arounds around our sites and have some of the conversation with our colleagues, because you're absolutely spot on. Our colleagues are the people that we need to help us explain this to our communities and one another, and our families when we have our conversation at the dinner table, that we can explain it to people. I think that's about it from my kind of summary, but I hope it gives you enough assurance that we are trying our best and going at pace.
Very good. Thank you. Lisa, did you want to come in on the consultation with people in work?
Yes, thank you. So just one extra point to add, really. We have been discussing this in our staff partnership forum, and we are trying to set up a special partnership forum as soon as possible after today's decisions to take them through all of the paperwork as well. And we've also got a workshop for our local negotiating committee, so that's our medical colleagues. So as well as the staff drop-ins, it will also be with our trade union reps.
Very good. Okay. Right. Bwrdd, James, do you want to come in? And James. Anna, want to come in? And then Lee.
Yeah, just a few observations. It's good that the consultation quality assurance process has been done and we've been consulting with it. Just wanted to know the 3 months, that's important. We've made that decision before now, but everybody's happy with the 3 months kind of time period. Just wanted to get that clarity. I welcome the Taylor Jones. I think that's very good. I've read quite a bit of the Welsh one. Mae'r Gymraeg yn dda. Da iawn. I think it is important that we have got everything bilingually, which is the case. And I just want to know, do we have a figure in mind, when it comes to all this consultation now, and how many are we expected to have, or how many do we want to have as responses to make it a valuable consultation? Because we see all these consultations with very low figures in them. I'm just thinking we need to be, obviously we are optimistic, we'll have a lot of responses, but kind of to make it a credible consultation as well. I'm just thinking, do we have any figures in mind, Elfenna? You're the guru in this.
I'd love it if we had every member of the community sharing their view. However, realistically, that's not going to happen. We don't have a figure in mind, but it's a case around, can we have the quality conversations as opposed to box ticking? Are we actually engaging with people properly? So it's less around the number, but I'd really like to think that it's in the thousands. That said, if we are inundated with feedback, it does mean that there may be a delay to our decision-making process in what we can bring back to board in November. So there's both an expediency but a quality kind of element to it. Can I just come back on the element of, thank you for the compliments, diolch, on the Welsh language. That's really great to hear, so I'll pass it on to our Welsh language translators who've been busily working. One bit I did omit to mention in the sense of have we, when it comes to the documentation, is that we've tested some of this with our readers panel as well. So in terms of gaining some initial feedback from people, we held an online session early on and we tested the questionnaire and some of the language, and we've also shared it with Llais to make sure that what we're trying to present makes sense, but also recognising that they are complex issues. So we've taken that on board and we've closed the loop with the readers panel as well, in the sense of making sure that that feeds in. But I hope that answers some of your questions.
And the 3 months then?
Sorry, 3 months, yes. Actually, it's not 3 months. We are statutorily, I think, required to go for 12 weeks for the level of this change. However, taking account of the fact that we've got holidays and people going to the Royal Welsh or whatever they may be doing, and we've extended it to 13 and a half weeks, which takes us tidily up until the end of August.
James, and then Anna.
Diolch, Chair. So it's just to, excuse me, croaky voice, it's just to build on the point around this being a clinically led process. So it was to add my backing as one of the clinical executives collectively that we are absolutely committed to driving this clinically, and to thank you, Dr. Kumar, and to Dr. Edmonds for the work undertaken. I wanted to share with the board a very interesting experience over the past couple of weeks, which has just been around some concerns that have come from some of our clinical leaders. And I really wanted to reassure colleagues that this is your opportunity to have your say. And building on what the team who clinically are here today are referring to, there is something about there is no predetermined options here. And I think it feels very important collectively and clinically to keep that emphasis on. So this is not just about the options to consider in the conversation. It's also about what else do you think could happen with your patient's best interests at heart. And it's just reflecting that really, Chair. Thank you.
Thank you, James. Anna.
I think if you didn't start this board meeting with a croaky voice, you're certainly going to end it with one. First, just to acknowledge, as various colleagues have said, what a huge amount of work it is to get us to this point. So while I think we are all feeling a degree of trepidation about the conversations that lie ahead, that should not overshadow the enormous amount of seriously committed work that's gone on over the last couple of years, and even possibly longer than that. I remember sitting in Haverfordwest with Ari saying the clinicians need some change in 2018, and here we are in 2025. So I think, really, really important to recognise the sort of the organisational memory and drive around this. I did want to ask one specific question, though, if I may. When I read that something is clinically led, one of the things I conclude from that is that it's shorthand for saying we've incorporated a clinical evidence base within what it is that we are proposing. And I suppose one sort of aspect of evidence that impacts on clinical outcomes, perhaps more so in people with chronic needs than episodic ones, would be about the role that families and carers play in their rehabilitation. I'm thinking particularly about stroke. Has that stream of evidence been considered where it's relevant in where we've got to so far? And is that something that you would like to encourage the public to talk to us about when we're considering what it is that's proposed here and how that might be adapted to get to as good a place as we possibly can do with this?
Very helpful. Great. You might want to come back on that.
Thank you, Chair. Anna, thanks very much. And I also want to touch on what Eleanor was mentioning earlier about the communication. Now, when we went through this process, it was a rigorous process. We went through the hurdle criteria, safe, sustainability, accessible, kind. We went through all that in detail. I think what we need to happen is that in the communication now, that kindness, what we discuss there, needs to, seep through to the public. And how are we being kind is by providing that high quality care has to seep through. I fully understand about the family's involvement with a chronic condition, especially stroke. And this is where I'm learning through this process. And what I can say is, while I was more scientific when we were in those meetings, saying this is the clinical standard, we made this is the evidence behind it, now I would like to take approach of more empathetic and communicating how we're going to be kind. I don't know if that answers your question. And at the end of the day, I mean, sorry, Chair, I'll be very quick. I've been to sites and spoken to people in these areas. And when I've spoken to people, the feeling I get is when you explain them, this is to improve your quality of care. This is not just for the sake of doing it. And they're happy. They want to be in the right place with the right specialist so they can go home early, closer to home. Thank you.
Thank you.
Thanks. I'd just like to echo what Senthil has said. The kindness and the patient and relative experience has to include outcomes. And if we can improve outcomes so that if somebody has a stroke, they recover much better, then there has to be a fundamental part of our assessment of the service we deliver. But of course, we have to recognise how difficult it is in a big geographical area for relatives to see their loved ones. And having that balance between a very, very good acute service and a kinder, closer to home chronic service is important. So all these things will need to be taken into consideration before we make the final decisions. But outcomes are very, very important. So if we get it right early, then hopefully the chronic disease will be better and easier to manage at home.
Very helpful. Lee?
Yeah, just to pick up a few points, really. So I think much of the discussion we've had surfaces the core dilemma we've got, really. So we have an ambition to deliver the highest quality, the highest standard and the most sustainable services we can, but that is not always entirely compatible with the geography and the rurality that we're working within. So if there were clear-cut, straightforward answers to some of these questions, we wouldn't be having the discussion today, because we already have the configuration that would work for our population. The fact is that it isn't clear-cut. There are trade-offs, there are challenges, and part of the consultation process is to step through those, have that honest conversation with our public so that we can explain the reasons why we think services need to be at a higher standard, more sustainable, but at the same time listen and have the discussion about the importance of the family and proximity to home that is going to be important within this. And through that, I'm sure, as you say, Chair, that will lead to some quite healthy debate and contention, and that's certainly what we're hoping, because that will surface some of those real dilemmas and those questions. I'm also completely expecting that we won't have the answers to every question that every member of the public has, because there's always there's always a question when you're doing this kind of work of how far down the road you go in designing the perfect solution, the perfect option, before you're then testing it with the public. And we've gone some way down that road. We've tried to come up with the best answer we can to the options that have been developed, but there will be quite a lot of details beyond that we haven't worked through yet, and that's because we want to make sure we're having that conversation with the public before we get to answer every single detail. And then the final point I was just going to make on Rodri's point around the level of reach we have within our population, that as Alwena says, we will be concerned with the number, we'll be focusing on that certainly, but what we certainly will be concerned about through the midpoint review is to what extent we're getting a balanced cross-section of our population, and that's going to be a really important measure for us, is are we reaching all parts of our population. And then the second half of the consultation period we'll be looking to focus in on those areas where we haven't heard enough voices from certain parts of our population.
Very helpful. Donna, and then I'm going to come to Phil.
Diolch, Cadeirydd. A few points from a llais perspective. Really grateful to see that Tylee Jones are back in the room, because that's important to people when they can identify with somebody like them. We know that the public, some of them may be users of this service already. Some of them may not know they need these services in future. So having a story about somebody that is in their age group or that might be like them in the future is really important. I think it's also important when we're having these roundtable discussions in the engagement events is to have clinicians there. I think it's made a big difference in the MIU story in PPH. We've been involved in those, and we've had people come away and really appreciated that they've had, you know, some senior clinicians sat around the table having that discussion with them. So it's not nameless people making decisions. They can have their questions answered face to face. And so we look forward to seeing clinicians out at these events and talking to people who are using the services. Diolch.
Very good. Thank you very much. I mean, I think you're absolutely right. The more that we can engage clinicians in these conversations, I think the richer the conversations will be, and frankly, the more credible, which is really important for the public to have trust in the way in which we're thinking and trying to make our decisions. Thank you, Donna. Phil.
Great. Thank you. Well, thanks for the discussion. I think that, first of all, just wanted to thank everyone who's been involved, people around this table, but also the teams and some of the patients and service users who've contributed to getting us to this stage. It has been a monumental effort even to get to this stage. I think it does recognise the complexity of what we're facing. 9 services, each with their own risks, pressures and opportunities. It also recognises, I think, the tensions and dilemmas that we face, and we've discussed a few of those today, where it's balancing standards and access, the need to make urgent change soon versus things that need to evolve over time. There are some real dilemmas that we face, and I think will need to be part of that rich dialogue with the public. We know that staff, patients and communities do often hold diverse, often conflicting views and about the way health and care is configured and delivered. And some will say this change is overdue, but we do need to remember that some will see it as a threat. And so we need to hold this space with humility, integrity and courage, I would say, when we have these conversations. And I think our clinicians will want to be in that dialogue with the public, because they're in the best position to explain the rationale behind these changes. So I don't think it's about defending a fixed position. It's about opening a meaningful dialogue with the public. So that's going to mean listening well, engaging deeply, and being really open to refining and potentially reconsidering some of the proposals that are being produced today. So this has to be about building something better, something that's safer, more sustainable and kinder for everyone who depends on our services. So thank you very much. It's a big item, this.
Indeed.
And I know there's going to be a lot of interest.
Lots of people know that one of my dilemmas is that in the past what we've generally done is offered the public a choice between blue and green. we've just said blue or green, tell us, and then we'll go and make that happen. And I think, harkening back to your point, Michael, there is a real shift for us to be able to engage in that co-creative, co-productive way with communities so that they feel fully engaged in this work. They trust us in our endeavours, but also they feel as if they've been instrumental in making some of these critical decisions. And I think that's what we've got to do. And I'm very reassured, Owen, by what you've indicated in terms of frankly, our written material. But there is something about the conversations we will all need to have around this table with communities. We will need to have difficult, challenging, occasionally uncomfortable conversations, but hopefully creative, liberating and delightful conversations as well about what those services might look like in the future. And I want everybody involved. So I don't want it to fall on just a few individuals inside this room. I want everybody to take an active part in that, because we fundamentally believe this is the right thing for us to do. Senthil, I'm really taken with your idea of kindness. And I think that is fundamentally what we're trying to create as an outcome in this space. People value kindness in the way in which services are being delivered. And we know that at our heart. So in many ways, we've got to find ways in which we can ensure that the process is a kind process, as well as the outcome that we're trying to deliver inside this space. I'm conscious that the kind of term of reference that we are beginning with in this consultation is, when you are unwell, this will happen. And actually, I really like the question, what will make you healthy? So when we talk about stroke, on the one hand, we need to give people assurance that should they have a stroke, they will be dealt with safely and with the best quality service. But there's a conversation about how do we stop people having strokes in the first place. So there's something about how do we have that community conversation about keeping people well, as well as being able to deal with their illness when they get to that particular point. My final point is, people will question our motivation for doing this. And I think we've had a really positive, energised conversation here about the drivers for the clinical services plan, which is why now, why these 9 particular services. And we are assured by that, but we will need to reassure the wider community that this is the right thing to be doing now at this particular time. And that our motivation is wanting to deliver better quality, safe services that absolutely translate this idea of kindness into how people want to experience our health services. So we need to get into, give everybody an assurance that that's what we're doing, notwithstanding the tensions that will exist in wanting to take this forward, because there are lots of tensions at the same time. But I'm hoping everybody around this table will be party to all those changes taking place and be prepared to roll up our sleeves and make sure that this is a fulsome consultation. It's one that is vibrant, it's interesting, it's contested, it's uncomfortable, it's challenging, it's rich, it's meaningful in terms of the outcome that we get to. And if we can co-design and co-produce an outcome that meets the needs of the communities and this organisation endeavouring to deliver sustainable, safe and quality services, what a fantastic outcome we would have reached. And that's where we need to get to over the next few months. So on that basis, can I seek the endorsement of the board to formally launch the clinical services plan? Great, okay. And we've obviously received assurance from Hewman and Co that we are compliant in terms of the quality assurance process undertaken so far. And to note the update on the urgent and emergency paediatrics implementation plan at Withybush Hospital. Thank you, everybody. Thank you for your contribution to the conversation. Senthil, Irie, thank you for joining the conversation. Arwenna, thank you to the team for the tremendous amount of hard work they've put into delivering what I think is really high quality consultation documents as part of this process. Thank you, folks. Let's break for lunch. Good afternoon, colleagues. Thanks for coming back so promptly from lunch. This next section of the board meeting looks at annual reports, and we're going to kick this off by looking at the Nursing Staffing Levels Wales Act Annual Report for 24-25. Sharon, I think you're presenting on this.
I am. Yeah. Thank you, Chair. Diolch Cadeirydd. So this report introduces the Health Board Nurse Staffing Level Wales Act Annual Assurance Report. It sets out the ways in which the health boards meet the statutory requirements of the Act, and it includes the extent to which the nurse staffing levels have been maintained. I just wanted to note that the extent to which the planned roster is maintained is also monitored at Quality Safety Experience Committee on behalf of the board, and that's next scheduled to go in on June the 20 in June meeting. So whilst this report summarises that the percentage of shifts where the number of nurses were deemed to be not appropriate is decreasing over time, we will explore that further in the QSEC meeting in June as well. I want to assure the board that all reasonable steps are taken to maintain the nurse staffing levels as per the requirements of the Act, and our operational teams apply their professional judgment to ensure the staffing levels where possible are maintained. So having regard for the health board's overarching duty to provide sufficient nursing to allow the nurses time to care for patients sensitively. The report also includes the impact of not maintaining nurse staffing levels and the impact that's had on care provided to patients by nurses. And for transparency, during this reported period in adult medical and surgical wards, there were no hospital-acquired pressure damage that met the threshold for inclusion in the report, but there were 2 falls, 1 medication error, and 1 complaint that did meet the threshold, and that's included within the report. And there was also 1 medication error incident which met the threshold as well. For the paediatric wards, for this reporting period, there were no incidents or complaints that met the threshold for reporting. So, in conclusion, I want to confirm that the Health Board has remained compliant with its statutory requirements as set out under the statutory guidance in the Act, and the Board is asked to formally receive the report, annual assurance report, and take assurance that the various statutory requirements of the Act have been met. I'm happy to take any questions, Chair.
Thank you very much, Sharon. Colleagues, any questions? Can I ask, because the report is largely a kind of data capture, what's happened, previous reports, is there a trend or a pattern to the data?
No, I guess in this report there's been a slight change in the metrics that we are reported in line with the duty of candour, which we've called out in that report. So some of the incidents that I've just mentioned now would not have been captured previously. What we would do during the time of the incidents is we will investigate and review those incidents and make sure that A, we've taken reasonable steps to mitigate, and B, we've got the right systems and processes in place to ensure that we can provide that sensitive care.
Great, okay. And just trying to link this into the conversation, Anna, we had earlier about staff disclosure for potential mistakes or things they might not want to disclose. Do we think there's a risk that there may be additional errors or mistakes in here that are just not being disclosed?
I mentioned earlier, and we'll pick it up in QSEC, we've got quite a detailed breakdown of the incidents over the last 4 years, which we'll bring into QSEC. There has been a change in pressure damage, but that was a deliberate change that we made in December 2023 around the reporting arrangements. So you'll see a change. But this requirements of the Act is that you would report pressure damage stage 3, stage 4. So that wouldn't impact the change that we made. Not yet seeing any decline in the trend reporting for falls, medication errors, and so forth. But we'll pick it up in more detail in QSEC just to make sure that we're assured. Yeah.
Great, thank you. Thank you, Sharon. Thank you very much. We're asked to receive the annual assurance. Can I assume everybody's comfortable with that as an action? Great, okay. Let's move to our maintaining good governance section, and we're going to report of the Audit and Risk Assurance Committee. Rodri.
Okay, thank you, Chair. All right, as you can see, we've got two reports. I'll just take one at a time. The first one, then, if you look at the 15th of April 25, there was no advice to the board. Just a few things kind of I'll pick out. The committee considered the standing orders and scheme of delegation and recommended both to the board for approval. In relation to Audit Wales Plan 25-26, it was noted that this will include core work, a review of arrangements to manage estates, and a review of radiology services. A thematic review into cancer services will examine local progress being made towards achieving Welsh Government targets and quality standards for cancer services. And then if you go to the internal audit plan for 24-25, and the following internal audit reports were received, and you can see there the substantial assurance and reasonable assurance that that were given. And then the recommendation is, well, I don't know, Chair, is kind of to approve the revised standing orders and scheme of delegation, and also to take assurance from the items that the committee is providing assurance on. That's in the second one. I'll do that at the head of it. Yeah.
Okay. Are people happy to approve the revised standing orders and schemes of delegation? Helpfully, everything's highlighted in red, so we can see where the changes are.
Sorry, just one question on that. Is this last year's delegation, or are we signing up for the new delegation for this year?
This year. Yeah.
Because we still got sustainable resources and strategic development and operation on page 68. None of the new committees. It's on page 68, Schedule 3. So just to note it.
Thank you for... Yeah, we'll amend those accordingly, but thank you for that.
Thank you.
And shall I go on to the 8th of May?
So just to... are we happy to approve them, subject to the amendment that Anna's recommended, and take assurance from the items that the committee is providing assurance on? Great, okay.
Okay, thank you, Chair. And then if we go to the 8th of May, we had an extra meeting due to the amount of perhaps internal audit that were deferred, so we thought it wouldn't be advisable to take them all in one committee, so we had an extra meeting. Therefore, nothing again to alert the board to. Just quickly regarding the Assure, the internal audit plan for 24-25, and the following internal audit reports, so you can see those that were reported on. The committee received assurance on the adequacy of arrangements for declaring, registering and handling of interest, gifts, hospitality, honoraria and sponsorship. Also, you can see the committee received assurance that there are adequate processes in place to monitor the implementation of the NHS non-statutory instruments update and the Welsh Health Circulars. Subject to minor amendments, the draft ARAC annual report was approved for submission to the extraordinary public board meeting in June 25. Importantly, I just want to emphasise that the next point, the draft head of internal audit opinion and annual report. Reading what's on the paper, it was going to be a fine balance of what the overall opinion will be. But I've had, as chair of ARAC, I've had a meeting with Joe and James Johns from internal audit, and kind of the news was very welcomed in a way. He has confirmed that the head of internal audit opinion will be reasonable. Therefore, I have to thank everybody for all their hard work. Joe and the team, I have to say, kind of you work hard kind of in getting everything together, and also the dialogue that you have with internal audit, and thank you for all that work. And so if we just move forward, the only other one I want, and it will be kind of as a, you can see in the recommendations, but the committee discussed a report regarding the banking arrangements, which had been prompted by proposed increases in bank fees and the Health Board's current commercial banking provider. Whilst the standing financial instructions allow for the use of commercial accounts, they should only be where there is a clear rationale for not utilising the Government Banking Service, GBS. Therefore, given the proposed increase in fees, it was considered timely to review arrangements The proposed transfer of accounts to GBS will make a small cost saving and avoid additional future costs. The committee discussed the matter in detail and received assurance that provision has been made for a test period before accounts are moved. The committee supported this, therefore it's down to the board's ratification. Thank you.
Great. Hugh, do you want to add anything to that?
Chair, no, I think Rodri has articulated the issue. The default position is government banking service. We were benefiting by not using GBS for a period, but now clearly it's beneficial to transfer into GBS. There will be, I'm very conscious of some of the very significant payments that we have that are very time critical, and there will be a standard kind of test process that we will follow. That is quite a well-trodden path in terms of transfers into GBS.
Right, okay. Any questions before we agree this? Okay, can I ask that we approve the decision to close the main and general Barclays accounts and move all exchequer transactions to government banking service? Great, okay, thank you. Let's press ahead with that and take assurance on the items the committee is providing assurance on. Diolch, Rodri. Joe, let's move to standing orders, standing financial instructions and schemes of delegation.
I think our RAC Chair's kindly got that approved for me, Chair.
So there's nothing else?
Sorry. Thank you, Chair.
There's nothing else anybody would want to add? Other than Anne's amendment?
Yeah.
Great, okay. Let's move to report of the Quality, Safety and Experience Committee. Anna.
Thank you, Chair. In the interest of time, I will move straight to questions, but to underline the sort of the complementary nature of the agenda items that we're discussing in QSEC alongside a number of our different board discussions today, which I hope gives board assurance that we can be confident that we are creating those connections across our agenda at various different levels of our organisational governance, thanks in no small part to Sharon and Joe. Happy to take any questions on the report.
Great, okay, thank you. Colleagues, any questions or? No? Okay, thank you. We note the items of the committee and take assurance from the items the committee is providing assurance on. Thank you, Anna, and the team. Let's move to report of the Finance and Performance Committee. This is the first meeting of the Finance and Performance Committee. Michael.
Thank you, Chair. Yeah, actually, echoing what Anna just said then, our items of alert, again, are matters which we have considered here in the board today on performance of some areas, the accountability letters, same with the areas matters of advice. So I take those as effectively read. What I wanted to emphasise and get across is you will see reference several times in this note to the word monitor and measure, and that's because when we will have a real focus on when there are promised actions, that we have that they are monitored and measured to see if those promised actions are effective and moving the dial. I think that's something we need to kind of really push forward on and have a very close eye on that as a committee. So I hope that comes across from those notes. It was certainly the tenor of the meeting, if I put it like that. So in that respect, in terms of matters to approve, I'm going to defer to Hugh on the item there in respect of ophthalmology services.
Chair, we've got the next paper includes the procurement paper, and these are matters which require the board's approval because they take us over the board approval limit. So there's 3 items on there. One is outsourcing of ophthalmology. The second one is around virtual application delivery and network load balancing. And the third is a contract for fuel oil. Pending board agreement to these will then be submitted on to Welsh Government and DHCW in particular for the second one for their consideration.
Great, thank you, Hugh. So dealing with the first item first, we were alerted to the fact that only 50% of delegated budgetary accountability letters have been signed. I'm presuming this is what we talked about this
all
morning.
done now.
Very good. Okay, so we're all sorted on that. So in terms of outsourcing of ophthalmology services, everybody comfortable?
Want me to say
Andrew.
anything? I suppose just to say that the outsourcing award is part of a national approach this year to the allocation of recovery money. They've, at all Wales level, the NHS Executive and Welsh Government have commissioned a range of activity to support planned care recovery across some of the surgical treatment areas as well as outpatients, diagnostics and diagnostics at the moment. This is we've got an allocate. We've obviously got the opportunity through cataracts to utilise that agreement, and we've had a allocation from them that would enable us to achieve the activity levels we need to hit in our annual plan this year, and it would be funded.
It goes without saying, perhaps it doesn't go without saying, this is good value, this contract.
Chair, it's been through a procurement process in order to determine good value. So we've got a process. So yes, it is. We can be assured of that.
Okay.
I was going to say one thing I will add is that we will, with the conversation we've had with Welsh Government, is that if we can deliver more activity for the same price with some of our regional options as well, then we are permitted to do that as well to get even greater value for the sum of funding that they've allocated us nationally.
Yeah. So my only question is we kind of focus on how much it's going to cost, and I'm wondering what will the value, how many people will receive treatment as a consequence of that expenditure? Have we got some idea of that?
I haven't got the figures, but that overall cost allocation is determined on the number of patients that we put through.
For cataracts, it will be circa 2,400 patients, and that will be, it's a whole pathway that we're procuring for those, so that includes the initial outpatient appointment, the treatment and any potential follow-up.
Great, okay, thank you, Andrew. That's very helpful. Is everybody happy to approve the award? Yep. Great, okay. And respond to the items the committee is alerting them to, which I think we've resolved. Note that the committee is advising us of, and take assurance from the items the committee is providing assurance on. Michael, we take from that the fact that you'll be like a dog with a bone, making sure there's the monitoring role is really about making sure there's progress around some of those areas. Thank you very much. Thank you, colleagues. Okay, shall we move to Hugh, the procurement report, and I think that broadly covers off what we've just said.
There were two
others, though, Chair.
Yeah, the two others on the list, Chair.
Okay.
But both of which I've alluded to, one in terms of digital procurement of virtual application delivery, and the second one for fuel oil, both of which will be as part of a national programme, the digital one through Digital Health and Care Wales, the fuel one through shared services.
Great, okay. Is everybody happy to approve both of these awards? Great, okay. Thank you. Thank you, Hugh. Let's move to item 19, which is report of the Strategy and Planning Committee. This is another new committee as well.
Thank you, Chair. The committee met on the 24th of April. There's nothing to alert the board to. The only area of advice, it relates to the infrastructure business continuity. So this just sets out the state of our current estate and all the risks associated with just the age of it and the number of maintenance. What the update says is that largely over the next 3 to 4 years, it's mitigated by funding by Welsh Government, but there still remains an underlying risk factor there. Apart from that, lots of areas of assurance in relation to this committee. We've also got a few items for ratification, and those are attached. So do you want to take that now, the ones attached?
Great. Okay.
So there's the fluoroscopy business case. and that includes the ratification of an award for contract for 1.846 million to T. Richard Jones Limited.
Yep.
The other paper is to ratify the energy and carbon programmes of work, and also there's another paper also to ratify the 5th and 6th LINAC. So I don't know whether you want to just take those in turn, Chair.
Could we just go through them? I think it would be helpful for us just to go through them individually. So, if we take the first one,
that'll be Lee, I think.
Yeah, thanks. I'll pick it up. So, as the paper explains, this is in relation to a replacement of the fluoroscopy unit in Withybush. It is funded through Welsh Government funding, and so this is we're seeking board approval today because it's in excess of the £1 million threshold. But the funding is there for it, and we've gone through the procurement process as stated, so seeking board approval for awarding the contract.
Great. Can I just clarify? So obviously a number of organisations are already on the framework contract, or they're on the framework, and then we pull off. Are we asking individuals to tender?
Yeah, that is part of the framework. We would be asking individual organisations to bid against the piece of work that we
Fine. Great.
put out.
Okay. Fine. Okay. Great. Okay. Are we happy to approve the award to Richard Jones Bettus Limited? Great. Okay. Thank you for that. Energy performance contract.
Diolch, Chair. This is my new portfolio, first paper for it. So the report, if it take as read, so the purpose of the report is to provide assurance to the board on the progress for our energy performance contract delivery plan in line with our ambitions to be net zero carbon by 2030. So the existing 10-year contract ended on the 31st of March, and outlined within the paper is our transition plan to our new provider. So this has been through the Strategy and Planning Committee on the 24th of April this year. The report outlines the status of the scheme, outputs, the financial and governance arrangements along with risks and implications, next steps. And it's here at Board, Chair, for assurance to be considered by the Board and to approve the submission for the Welsh Government business case in line with the investment grade proposal in the paper. Happy to take comments.
Thank you, James. Colleagues, any thoughts or questions? No? Okay, can we take assurance from the current project development, including the financial and risk status? Presuming yes. Approve the submission of the Welsh Government business case in line with the tabled IGP outputs and following Welsh Government's arranged SALEX financial technical review, hopefully to secure the necessary funding. Note the further procurement work and approval requirements to appoint the Health Board client-side support team. Note the further legal work to develop work contracts in line with the framework. Great, okay. All noted. Let's move to the South West Wales Cancer Centre 5th liner 6th bunker business case. Lee.
Diolch, Cadeirydd. So this is a case that, a paper that went to the Strategy and Planning Committee. It has subsequently been slightly amended, and we had Chair's action meeting yesterday to consider those amendments before coming to board today. The context is that the Health Board, along with Swansea Bay Health Board, agreed a strategic programme case back in January 2023, and a key priority within that was the expansion of radiotherapy capacity. So the team in Swansea in particular, but in conjunction with our teams, have been working up a business case and plans to expand the LINAC capacity, which is the capacity to provide radiotherapy within the Singleton site. So the proposal here today is for board to support progressing with that plan, in principle, obviously, ahead of the formal business cases being produced. Specifically, what we're seeking to do is firstly, expand the LINAC capacity, recognising a current under-provision across South West Wales to a 5th LINAC, and then, in addition to that, a 6th bunker alongside the existing 5 LINACs to allow for replacement of the LINACs as part of the national replacement programme in coming years. We are anticipating beyond that there'll be a need for further capacity increases, as the paper says, and we are assessing the opportunities to provide that additional capacity within the Hywel Dda footprint. That would be our ultimate ambition. There are practical questions we need to work through in relation to that, but that's the shared ambition of both Hywel Dda and Swansea Bay Health Boards. So I'm happy to take any questions on it, Chair.
Colleagues, questions? Eleanor.
More of a statement, really. I think it's a really good example of
I just want to
working.
I just want to add to what Lee said just then. We did have a chairman's action meeting. We went through the. So this is a development shared with. I will let you back in. Sorry, it is a development shared with Swansea Bay Health Board. They're not going to approve it this week, and they're going to wait until July to look at it in more detail. I think it's worth our health board knowing this. And the extra costs, we will obviously need to agree what the share of that is going to be with them. But from our point of view, we felt that the demand for these services is so great. The need to upgrade and refresh and modernise our equipment was really, really great as well. And the number of cancer patients, it's quite critical to what we need to do. So I think when we had our meeting yesterday, we had no doubt that this was the right approach to go. The longer you leave it, the more the capital costs will cost you. Potentially the longer you leave it, the more modernisation costs. So it's quite an opportunity for us to go ahead with this. I just want to add that in terms of that. Sorry, Eleanor.
Thank you. Thank you, Winston. Eleanor.
Okay, diolch Cadeirydd. I was just going to comment that it's a really good example of joint working. Likely, I share the aspiration that the 7th could be in Hywel Dda, but as long as it benefits the population of both sides, I think it's great. The one question I have, and this is a very stupid question. Do you actually mean a physical bunker? Yes, it literally goes into the ground on top of. Yeah. I just wanted to check because, you know, I've said before I speak Welsh, I speak English, I don't always speak NHS. That's fine. No, that's brilliant, thank you.
So, linked to that, so the 6th LINAC, or the 7th, going into the bunker, would not be for immediate use, or would be for use if one of the other LINAC machines malfunctioned or broke down?
Yeah, so each LINAC is set within a bunker. So we'll have 5 LINACs in the bunkers, and then a 6th vacant bunker, essentially. And the idea behind that is when it comes to the point we need to replace one of the existing 5 LINACs as part of a replacement programme, you can put that into the 6th bunker, so you don't have a gap in service provision as you're making that transition. So that's why the 6th bunker is necessary.
And is there benefit, Lee, to doing? Because it feels to me as if we're procuring a very expensive piece of equipment which will just sit in a bunker until such time as we want to use it.
No, sorry, the 6th bunker won't have a LINAC in it.
It won't have a LINAC in it.
No, that it's there ready for when we need to make the expansion, make the replacement, so that the new one, when it comes, would go into that, and then you can decommission one of the others.
Okay.
Just for clarity, once the LINACs are set within the bunkers, they are operational within those bunkers, not stored. They are working devices.
Yeah. Thank you, Maynard. Bill.
Just to check with Lee, and it's a similar check on the other two. So for this particular programme, we're committing to working this business case up, or we're committing to the spend that's within the paper. Just wanted to check that.
So we're committing to work the business case up. The business case itself will then need to come back to boards for ratification. It was important to provide the board with the visibility of what that means, because obviously the very first question the Welsh Government will ask is, are the board supportive of this development and the likely associated revenue costs. But there'll be further business cases beyond this.
So, because that's an important point, isn't it? That we're committing to that business case work, knowing that there are likely to be revenue costs, but as part of that business case work, we'll know what the counterfactual would be. That, you know, how would we manage those cases otherwise? Or so I suppose from that point of view, it's the business case development that we want to support. I did have a sort of question about the other two, just to check that the difference with this one compared to the other two is there are no additional revenue consequences to the two other items that we've just approved. So that's which is important also for us. Yep.
Yeah, great. Okay. Hugh.
Chair, yeah, just to clarify, I guess the situation on revenue for this is different for Swansea Bay and for us, in that Swansea Bay will be creating the capacity and therefore will have the direct revenue consequences of the creation of capacity. Our revenue costs will be driven by the demand of our patients using that service. So naturally, with cancer rates projected to increase of the future, we are naturally going to see more demand for that service anyway. So it's the demand that's really driving the revenue consequence for us in the future.
Okay, thank you for that clarification. So on the basis that we will receive a business case in the future to give further consideration to, are we happy to proceed and support the development? Great, okay. And then I think obviously that involves a scoping meeting with Welsh Government to take this work forward, and to undertake further reviews for additional capacity for either within the Halvar footprint or Swansea Bay, and acknowledge the risk of the fifth LINAC may not be fully operational by 26-27. We're happy to do that. Great, okay. I visited Singleton and to look at the cancer service several months ago with Jan Williams, the chair of Swansea Bay University Health Board. It was really impressive, and these machines are just outstanding. And Lee, I want to say, I thought the paper was well prepared. The explanation in the paper was really, it was simple. So it kind of appealed on the basis, it clearly explained what the rationale behind it, but actually what they did, what the machines did. So really good, well put together. Great. Okay, let's agree that and move to our next item, which is report of the People, Organisational Development and Culture Committee. Eleanor.
Thank you, Chair. It's the first one I chaired. It took place on Tuesday. There was only one advice to the board, and that was relating to something that came out of the staff survey, which was around the non-reporting of incidents, which you've already touched on. There was a second question, which is not an advice, but Lisa will talk through. The staff survey was presented in its first cut, and there's going to be a deep dive and more work done into that. And the attached paper is about the staff survey, which I will allow Lisa to talk through. If not for anything else, I think my voice is just about to give up completely.
Colleagues, any questions based on the fact it's a verbal update as opposed to a paper? No? Okay, thank you, Eleanor. Very helpful. Let's move from there straight into our staff survey recommendation. Lisa.
Okay, thank you very much, Chair. I'm conscious of the level of detail that's in this first paper that's coming to board, which is around our staff survey findings from last year. I'm sure some of you will have wanted to see more analysis around the 100+ questions that were in that survey. And what we need to do now is what you referenced earlier, Chair, around being inquisitive around how do we look at the information that's provided through lots of different lenses. So what does it mean for different professional groups? What does it mean for our protected characteristics? Has there been a different experience in Ceredigion to Carmarthenshire? And that's the work that the teams are undertaking now. We've got 30 plus staff survey reports in the workforce and OD team that will be analysed through that lens. The highlights of the report, however, is that our response rate this year increased to just under 20%, so we were 12% in 2023. These are the best results so far for our health board, although it is still very low and we do need to do much more. Almost 2,400 people did give their time to take part in the survey. It is a one opportunity survey, so you can't start it, pause it and go back and do it. So for those people who did undertake the survey, we are truly grateful for the time that they took to do that. So diolch yn fawr. Our staff engagement score was 71%, which is consistent with what we see in the IPAR around the monthly pulse surveys that we undertake with our staff. There are 10 themes within the staff survey, and you will see in there that we score lower than the Welsh average in 6 of those 10 areas. So we absolutely have work to do to look into all of those areas. And you can also see in the report the findings by directorate. So this is pre the introduction of the clinical care groups. The information has been shared in the format that we have with all of our managers. And I think what this tells us when you look at the colour coding for our staff experience is that when staff experience isn't right, you will see other things within that directorate, within that service that also are not right. And again, comparing to the IPAR, the areas that are red in the staff survey are predominantly red in the IPAR. So it just correlates that staff having a good experience ripples through an organisation in terms of our performance. We had 6 areas of focus in the 2023 survey, and I'm pleased to report all 6 of those areas improved in 2024. But what this is telling us is that I think there are 4 key messages really. One is that we have to get out there and engage with our staff for them to see and understand the value of contributing in the survey. This year we actively held drop-in sessions, we went to dining rooms, we went to wards, we went to departments, and we saw that increase in engagement. This absolutely tells us that our staff are committed to do their best for the organisation. We had really good results around I'm willing to work, to go the extra mile. People at work, additional hours unpaid to provide the care that we need for our patients. We have improved from last year, but we do have much more to do to support the people within our organisation. So the conversation that I've had with the Vice Chair is that we will be bringing a deeper dive of the staff survey into our next People and OD committee in August. We are already looking at, and we have had a workshop with our partnership forum around the initial findings, but what more do we need to do in there? We are also taking it to our professional groups, and our LNC will be seeing the medical staff results, so that again they can be involved in the process of how we can improve, and we are looking at it through the EDI task force as well. And we've got 2 pieces of work linked with the EDI task force around sexual safety and bullying and harassment, which would be really powerful to see the staff survey results through that as well. So I'm happy to take any comments or questions, Chair.
Thank you, Lisa. Very, very helpful and in many ways reassuring. I think it's fascinating that we're able to correlate some of the challenges around performance in the IPAR with staff engagement and satisfaction inside this report. That says an awful lot to me about how those services are managed, to be honest, as well as the culture and the environment. It says who is holding those services together and driving that performance kind of inclusive culture build inside that space. Yeah, before I witter on, Rodri.
Just a quick comment. I thought the People's Committee on Tuesday was very interesting, and we had a good dialogue, good discussion regarding the survey. The only thing that was kind of raised, perhaps, and it would be good if they could look into that in general, is the survey itself, isn't it? Kind of, it's a pity that it's not more user-friendly. You either open it up, do the survey, you can't come back and finish it off, and I think that that needs to go back. Just to say, I know it might not be that easy to do so, but I think 19.7%. Yeah, I think we need a kind of a greater input into this, and I think if there's a way of trying to address that problem, I think it would be a good way forward.
There is something about, so building on that, it's very low. I know that we can explain why it's very low. It's very hard for us to impute the data credibly for the whole of the workforce based upon just 20% completion rates, because it can be the 20% of the most dissatisfied or disaffected, or the most satisfied and the most affected, and highly likely that those who have no issues either way will just not bother responding. The other issue for me is I think it's a long survey. It takes 25 minutes to complete. I wonder how many people 10 minutes into the survey think I've had enough of this and just stop it. And would we know, I would be interested to know whether we could understand the drop-off rate during the course of completing the survey, because I think that would, all the evidence suggests nobody is going to complete a survey. I wouldn't complete a survey of that length, frankly. I would have to have a real issue and be purposeful in my reason for wanting to complete it, to stay the course, to endure the course of 25 minutes. Sorry, Lisa, that's not, I appreciate it's out of your control. It's not within your control, but I just think we're using a tool that's not within our control to obtain a response on which we are planning a whole series of workforce interventions and changes.
Absolutely. So in response to that, we are part of the working group with HIW. We do regularly feed this feedback back to them. We heard in People and OD committee on Tuesday that the reason why it's a enter it once and you can't save is because of people thinking if you save, you've got to have an identifier, and therefore anybody worried about it being an anonymous response, that they have decided that the only way to make sure it's truly anonymous is to just go in once without needing a password. But we will continue to feed that back. And part of that was why we introduced our monthly pulse surveys in the health board, because they were much shorter, but some of the questions are the same, so that we can on a monthly basis test with some of the NHS survey responses, but agree.
I do wonder, I mean, the UK Statistical Authority is responsible for accrediting good statistical examples. I wonder what their view might be on this, because this is a Wales-wide survey, so it's not just a small thing, it's a very large thing. If it's failing fundamentally to capture more than 20%, 22% of the workforce, it's not doing its job. It is not doing its job. And I think it's about a user focus. So I think it's more about working with users and how users want to respond to these conventional tools that should drive the way in which they're designing it. It doesn't feel, it feels unsatisfactory to me as a tool to establish workforce experience. Several, Phil, do you want to come in? Anna, do you want to come in?
I mean, we Lisa, I'm sure we'll feed that back to the working group. We of course have to remember that some organisations have managed to get much higher percentages. So I suppose I expect that would be fed back to us. So
well, but those organisations are very small generally, aren't they?
They are, although
they are much smaller than us.
Yeah, so some have got. Yeah, no, I accept that. I accept that. I'm putting critique back to us that okay. I'm sure that would be what the national team will say, but let's make sure we feed that back, because I'm sure I agree with you, it's bound to be one of the big factors as to why we find it hard to get a really high response rate, and that's what we would want.
Is it compulsory?
Yes.
I just think it's deeply suboptimal as a tool and as experience. I think it's absolutely problematic that we're enforcing this on the workforce, who are evidencing the fact they haven't got time, energy, or commitment to want to deliver this back in its current form. It just feels really problematic to me. We would be hard to justify this if, as a tool to measure our workforce performance, if someone externally said, how do you know everybody's happy inside your workplace? Sorry, Anna, I'm going to stop talking.
Yeah,
Anna, and then Anne.
Chair, I wonder if your inclination to complete the thing will change once Anne adds you to her WhatsApp group when the next survey is launched, because not doing it then is simply not an option. On a more serious note, though, and to build on a point I raised earlier on in today's agenda, I don't think we can let this item pass without explicitly acknowledging the paragraph in the report on page 8 that relates to staff safety, and an unequivocal statement that this theme, and the word theme is being used, showed that staff feel unsafe in reporting errors, near misses or incidents, and that there's a perception that those who do report are treated unfairly, and there is little feedback after doing so. A more damning indictment of our culture is hard to imagine. Now, we may want to argue that this is a small sample. We don't know whether or not it's representative, but frankly, anybody who's saying this in our organisation is ringing a very alarm bell for us, as far as I'm concerned, and that would be backed up in all the evidence that sits in patient safety literature. So I am particularly interested to know how this landed when the exec team took this report or a version of it, because presumably it's been through that route already. And what level of urgency did you determine was needed to address the issues that are raised by those statements on page 8 of the report?
Yes, please.
Maybe I'll start. Well, I think when we look to the report generally, it's very sobering. I think not just that paragraph. I think from the response rates, but to across all the domains. I think even though we're roughly similar to all organisations, it's very low scores across all the domains. And I think we felt that when you look at the Chief Exec's office, we had a much more rosier picture of the organisation than what we were hearing from the organisation. I know you see that in a lot of organisations, but I think I personally found that very sobering. I suppose the point that you make is sort of reverberates with the comments you made before about lack of engagement and low incident reporting. I mean, I guess they're all the same issue, and perhaps this gets behind why that might be and probably validates the concern. So I suppose the answers that Sharon and Lisa have given in the past, earlier in the meeting, as to how we're trying to approach this, how we're trying to approach it, I suppose the question is, the answer to how we solve this culturally, of course, is very much deeper. It's not going to be one single action. So I suspect all of these pieces of work linked together, whether it be the EDI task force, the work that Sharon was talking about earlier, the work that Lisa was talking about earlier around well-being of the workforce, all of those things I think would link together. And my other point would be that we're relying on, from a operational management point of view, is that the OD programme that we're putting in for those managers needs to have this as a really key part of that.
Sharon, did you want to come in?
Thank you. I mean, just building really, Anna, on what we talked about earlier in terms of the immediate response, in terms of what the corporate team are doing, especially in relation to the incidents and the concern that potentially people aren't reporting incidents when they should be. I think what the work that we're doing with the clinical care groups now is just making sure that we remind the managers, investigation managers with incidents, that they take the time to provide feedback to staff and they document that so staff feel valued in reporting those incidents. but also working to develop some trigger lists as well, just in terms of systems and processes to make sure that people know when incidents need to be reported, and maybe changing some of the terminology that we use, because we use the word scrutiny panel, which in itself maybe we need to think about switching that to learning from events approach. So we're just changing the narrative that we're using within the organisation to make it less punitive and make it more culturally acceptable to be reporting and getting feedback. And then it links in with a lot of the work that we've been doing over the last year around escalation to make sure that incidents are investigated and closed in a timely fashion, so we don't have historical incidents to close, so that there's that more immediate feedback coming through to staff as well. So and then linking it, as I said earlier, to that speaking up culture at a micro and a meso level as well. So some practical things that we are doing, but I think it all contributes to that cultural shift that we need to be seeing.
I wonder whether, I mean, it seems to me there's a unique dimension to this within health service organisations. If mistakes or errors are made, they are potentially deeply serious things because they impact upon patient health, patient welfare, patient safety, and the consequence can be enormous professionally for individuals. So there's already quite a lot of reasons why people are nervous or anxious or underconfident about reporting something that they might or might not have done, notwithstanding the response of the organisation or the manager or the particular environment. I just think that broader culture of the seriousness and the gravity with which we attach to a mistake, an error, or a particular problem adds an additional weight to the incident that might have occurred. I wonder whether we need to just, and in view of that, I wonder whether we need to dig a bit deeper into understanding people's reluctance or their anxiety. It might very well be because they feel they're going to be judged or castigated as a consequence of disclosing something, but it might also lie with this deeper insecurity or lack of confidence around that their professional competence will be judged and deemed to be, poor or not at sufficient standard that we would want. I just think there's probably more to this that we ought to be investigating than just the sense that it's a culture where people don't feel they can speak up.
Just very briefly come back, Chair. I agree entirely with you. This is an evidence base where I can claim some knowledge, and for that reason, I think not because I know it, but because it exists. We don't need to be in the territory of speculation. We can go to that evidence base. We can go to the patient safety literature. We can understand how patient harm comes about in services, and we can then apply those hypotheses to our own particular situation. I think we've got the potential to be usefully and effectively curious about this, rather than needing to cast around wondering what on earth is going on. I suspect that the version that we have of the lived experience of our staff collectively around the board table is probably at some distance from the raw reality of that lived experience on the ground. And that is a space where danger lies. And so I think that the more we can get close to that sense of lived experience, which will never be mediated through a staff survey, that's not how we get that information, and we all understand that. But the closer we get to that lived experience of what it's like to be a member of staff on a ward, in a team, in a hierarchy in this organisation, the better our chances, alongside with that evidence base, of actually making some real progress on this.
I completely agree. Thank you. Did you want to say anything, Phil?
Well, actually, I was going to say something similar-ish. I mean, I've read quite a bit of the literature, maybe not as much as you, Anna, but I'm very aware that evidence is out there, that the healthcare generally, people generally are more nervous at speaking up than other industries for all sorts of reasons, that some of which you've described. But I do think the leadership of the board does matter in that. So how each of us, how we as a collective, and how individual executives carry out their roles and lead is really important in this regard, and it filters down right to the front line. So if we have a more curious approach, then people will be more likely to speak up. as Sharon says, if we settle things, if we have scrutiny panels, then that will start to close things down. It doesn't take much for that data feed from frontline to be closed down completely. So part of this will be about our leadership. Part of it, we've got to try and get much closer to understanding what's going on at the front line, what it actually feels like. But we kind of know this to be. I agree with you. I don't think we can say, well, that might be a small sample. There might be just the disaffected ones. I think we have to accept that that's real. I suppose what I'm not quite sure yet, and probably needs a bit of a gathering of colleagues on, is how we get to that front line to get that understanding of how it feels to be led by us.
So could we ask the Quality and Safety Experience Committee to kind of pick that up and kind of do some more reflection and analysis around what would help us in those circumstances, because we do need to know more, and I think we appreciate it's more complex than the data in the People's Survey. Fine, okay. My last point, I think you mentioned it. It would be really good to see the data cut by some demographics. Age, is it the older population within the workforce that is responding in a particular way? When we see that 72% of those who responded think we're an inclusive organisation, is that a white response? Does that include everybody? Does it include, could we understand how different communities have responded in the data? I think we really need to see that to understand the depth of it and to bring a deeper level of analysis to the survey. Notwithstanding, I've got concerns about the survey. We shouldn't throw away the fact we still have quite a lot of data presented by this that we can
use. And we do the pulse surveys as well.
And we do the pulse surveys as a consequence of that. Anybody want to add anything more to that? Oh, Anne, yes.
Sorry about that. It sounds a bit trivial after the seriousness of the conversation we had, but on that topic, just a quick say, for quite a while now, haven't we, Lisa, we've had issues with data. I put the information in, but nobody ever comes back to me, and that can be a strong element of dissatisfaction when you're reporting incidents, but nobody's coming back and telling you what's happened. If you've done something wrong, they'll tell you fast enough. But if it's something else, they need to be feeding back a lot more data. So there's that element in your safety part. The other side is in 2023, we only had 12%. We went up to 19.7% this time. And that's really the hard work of Lisa's team. They went out with laptops, and the trade union team. We went out with laptops, we went to wards, we actually sat down with facilities in your coffee break. Oh, look, we set it up, do you want to do it? And that helped it. But it's the trust value, and that kept coming back from the reports that we've had as a trade union team.
Thank you, Anne. That's useful on a number of accounts. And I'm not, my dissatisfaction with it is not a criticism of the team, Lisa. I suspect the team's working extremely hard to make this work. I think it's more about the instrument itself and how it's operating. And I think you're right. I think if we sustained a culture of improvement that said it isn't, if you give us an idea where you think something can be improved, we're as interested in that as something that we're not doing right or individuals not doing right, then I think that would help across the board.
Well, in 2023, the trade unions went back to the people who designed this survey and said, this is unfriendly, unusual, and it counteracts. You ask one question, then you ask the negative, and it doesn't seem to correlate. Yeah. And people couldn't figure it out. So we did feedback, but literally it's there, we're doing it, wasn't it? Sorry.
Okay, thank you. Yes, please, Sarah.
So I guess it's a broader observation given what I've listened to this morning. And forgive me, this is my first board meeting, so I'm going to try and say something helpful, but I don't know whether it will be. So I've listened to a lot this morning about our desire for more action around DE&I, about being kind in our services, about our wanting to have our staff engage in the process of improving our clinical services. And then I look at the results here, and 3 of the themes where we've gone backwards in our scoring is inclusion, ability to contribute towards improvement at work, and compassionate culture. And it feels for me like there is a real gap there between potentially our board aspiration and what we're articulating here, and how our people are feeling. And for me, there's a big gap, and I don't know that I have assurance so that we are acknowledging that gap or quite how we're going to go out bridging it. So it's an observation, really.
As I've said to Anna before, helpfully unhelpful. No, you're right. You are right. I mean, it does. I mean, there's a disconnect between our aspiration, and our aspiration is based upon what we hope is happening. It's partly a hopeful thing, as opposed to just being an aspiration, and what we see in the data. I think it warrants further investigation. I think the numbers are unreliable, but I think it warrants further investigation and something we should think about and constantly be aware of. Lisa?
We will absolutely take that away. Every report that has been produced has been shared with managers, and managers have been asked to work through their information, work with our team, and come up with what are the 3 top things in their results that they need to focus on, and work with their staff around how they're going to do that. So that's where we are at the minute, where we're collating back now. I mean, Andrew's team will be the bulk of that team in terms of what are the different things for the different teams and what each of them have found to then come up with the health board plan. But I agree with your overarching comment, and absolutely we will give that commitment to do that deep dive work and report it through People and OD Committee.
Thank you. Going back to, as we close this item, going back to Phil's comment about it needs to be led by the board, really, you know, the culture, the setting, the tone, the values and the behaviours. I have a slight frustration that we're not overt enough corporately in our behaviour for that to be recognised and for people to, you know, to see that as something that needs to permeate across the whole of the organisation. I think individually, within our respective teams, or as a IAM cohort, we would have those healthy, open conversations. But I wonder how, as a board, we actually set the tone for the organisation in that way. I'm not convinced we do. Yes.
And one thing, I mean, this could be maybe a discussion for a board seminar, I wonder, because it's complex, the messages that we give, I think, because we're asking some of our staff to do extremely difficult jobs in extremely difficult conditions. We're also having to find considerable savings as a deficit organisation, and I suspect a lot of staff will feel that really intensely. To some staff, we're not tackling fragile services. To others, we're going too far. I think so. When the message we talked about communication earlier with our public, I think our ability to communicate that message as a board to our staff is really important. The points that we picked up around inclusivity, particularly around co-production, all of those things, important to speaking up. I expect they might get lost in some of the other messages that we put out there. So maybe your point might be, maybe we do need a focus in a board seminar, which I know are crowded, Joe, but that could be an important thing for us to do.
Great, okay. Thank you. Let's close this item and acknowledging the good work that's been done in preparing the report to the current time. Can I move us to item 21, which is a report of the Health and Safety Committee? Anne.
Thank you. Thank you. In the effort of speeding up, I'll take you that the report has been read. Note the items the committee is advising them of, and take assurance that the items of the committee is providing assurance on. Thank you.
Great. No questions, folks? Everybody comfortable with it? Great. Okay. Noted and taken advice on. Thank you, Anne. Report of the Charitable Funds Committee. Anne, this falls to you.
Yep, thank you, Chair. I will again take it that colleagues have read the report, and obviously just would like to kind of pay further compliments to our previous Chair, Delith Rainsford, in terms of the work that she has done on this particular committee. You will see that there is nothing to alert, there is one advise, and you will see in terms of the assurance, the depth of content in which the committee works very hard in terms of overseeing and supporting and delivering those results, but happy to take any questions.
Great. Thank you, Ewan. Questions or comments? No? Okay, great. Let's note the items and take assurance. Okay, report of the Digital Data and Innovation Committee. This again is the first meeting. This is the first meeting of the committee. Maynard.
Thank you, Chair. The first meeting took place on the 22nd of April, and the committee was well attended with good clinical representation and participation. Committee agenda was primarily focused on giving members a good understanding of the current position in the three areas of its remit. Between the previous board seminar and this meeting, I think we successfully achieved that. The committee is very keen to see the areas in its remit develop at pace, using all the expertise and resources available to the Health Board. The committee wishes to alert the board to just one matter, and that's the memoranda of understanding between the Health Board and its university partners, which has expired. The committee is asking the board to ensure that these are complete and signed by mid-June, as expected. All other matters are as described in the report. The other thing that the board is asked to do is to ratify the terms of reference, which have changed slightly since the last board meeting, and I think have changed once more during this last week, which isn't reflected in the paper, where we now have an additional IM committee member, so the number of committee members will increase to 5 IMs.
Very good. Okay. Colleagues, any questions or thoughts? No?
Well, just to confirm on the university partnerships, I understand all arrangements are being put in place to get those memorandums of understanding signed by that date.
Great, okay. So can we approve the changes to the terms of reference? The Digital Data and Innovation Committee? Great. And I think we've just addressed the alert item as part of that process. Noted items that we're being advised of, and take assurance from the items that the committee is providing assurance on. Great, okay, thank you. Let's move to committee updates. No, let's move to report to the Regional Joint Committee. This is me. Yeah. Okay, I think a number of people, a number of IMs and execs in the room would have been in the joint committee meeting. This took place on the 7th of May 2025, earlier this year. It's the second meeting of this year, and technically the first formal meeting in a way. You've got the details in front of you. I have a sense it's an evolving meeting, so it's going to alter and change as we continue to identify the common ground that we're sharing between us and the work we need to undertake. It should ultimately become much more strategic in its focus. At the current time, it's quite there's an operational, transactional edge to the meeting, largely because we're looking to see what additional value we can bring to working together in terms of our resourcing challenges and delivery challenges. So that's largely where the work is at the moment. I think we are much more interested in thinking about how the two health boards sustain a service across this wider health economy of West Wales, and how we work much more with population health principles so that we move just beyond the creation and the development of blended services and think much more about the whole health of the population. But a good meeting, in my view. I left at a key strategic point, I think, to chair another meeting. Enough said. Are people comfortable having considered the report? Are they confident? And then are we happy to approve, ratify and approve and adopt the governance arrangements, including the RJC revised terms of reference, leadership, membership and transitional arrangements effective from the 7th of May? Yep. Great. If people would like, I'm conscious that it's one of those spin-off committees where it brings together some members of this board, but not all members. If people feel they want more information or they want to be more engaged in that work, then please let us know, because we're really happy for that to take place. Great, okay. Can I move us to our next item, committee update reports? Jo.
Yes, Chair. So this paper covers the remainder of our committees. So you've got updates from the Ethics Panel, Remuneration and Terms of Service Committee, Health Professionals Forum, Partnership Forum, Stakeholder Reference Group and the in-committee board meetings that we've held. There are no matters from any of those committees or meetings, Chair, to alert to the board. However, we do need to ask you to approve the terms of reference for Health Professionals Forum. And just to note, it's not in the paper due to timing, but the Remuneration and Terms of Service Committee did approve Mr Henwood's appointment as the Medical Director.
Great. Okay. So is there any questions or comments people would like to make about the cluster of papers falling within this item? Okay, so can we formally record the fact that we've received the update reports in respect of work undertaken, received the update report in respect of the in-committee board meeting, also the recent advisory group meeting, note the items that we're being advised of and take assurance on the items that's being assured on.
And just approve the terms of reference for Health Professionals Forum, Chair, if that's
And
okay.
to approve the Health Professionals Forum terms of reference.
Thank you, Chair.
Great. So can we move to our next section, which is working in partnership, joint committees and collaboratives.
Thank you. So there's 3 reports from the main joint committees we're part of outside the relationship with Swansea Base. So there's a joint commissioning committee report from the 18th of March, shared services partnership report from the 25th of March, and the Mid Wales Joint Committee report from April. There's always a bit of a lag because of the timings of committees. Just to highlight a couple of things, the Joint Commissioning Committee, we're due to have a joint session with the Joint Commissioning Committee on the 11th of June at our board seminar, so there'll be an opportunity for us to discuss there for board members. On the Mid Wales Health Committee, I'm going to be taking over the Chief Exec lead role from Hayley Thomas, just to highlight that, which I'm looking forward to. And the third point about the shared services partnership is that you'll have seen in my Chief Exec report that there's an accountability and governance review that's being undertaken at the moment, led by Simon Dean, of the shared services partnership, and that's a national review led by government. But I'm happy to take any questions on the detail.
Colleagues, any questions or comments? No? Okay, can we just record the fact that we've received the updates? And then if I can move us to item 27, which is a statutory partnerships update. I think this is Jill and Ardiana speaking on this one.
Chair, very briefly, just the detail is there, but just to draw out the fact that we're in the point of that 5-year cycle now where we are having to refresh the population needs assessment, the market stability reports, and similarly PSBs are working through their wellbeing plans, which will come to this board. And I think probably making the link with the refresh of our strategy and how important these documents are going to be, and some of that underpinning information that reflects our communities. And then finally probably saying, and it's useful to point out, as per Winston's report, that the PSB work was considered at your last committee. But I think the final bit for me is that the Regional Partnership Board is considering how well it's working and is undertaking a review at the moment with the chief executives of all the partner organisations to look at its effectiveness and to make sure that it is really connected with our communities and the organisations that are part of that Regional Partnership Board. So thank you.
Great. Thank you, Jill. Adriana.
On the PSB paper, I think I would just, in specific from what is listed from the 3 PSBs, I would draw the attention of a session that our chief exec, Phil, with some other colleagues, including the Deputy Director of Public Health and Alwena, attended with Ceredigion Council officers recently to discuss some of the issues around general well-being and health of our population and the social model for health. There has been some further discussions between particularly Ceredigion and Carmarthenshire public service boards around the regional working as one regional PSB, and some progress with climate change impact work streams of 2 of the PSBs. And hopefully some progress will be made also with Pembrokeshire PSB in that aspect to have a more joint approach to working on climate impact on health and well-being. Other than that, some of the details of the work of the 3 PSBs is included in the paper. Thank you.
Thank you, Adriana.
One small thing on the Pembrokeshire PSB, Neil Pryor, who has been much respected chair of the Pembrokeshire PSB, is stepping down because he's left his cabinet position in the council. So there'll be a re-election of a new chair of that PSB. Also, I happen to be the vice chair of the Pembrokeshire PSB, and so both posts will be up for re-election. Okay.
Thanks, Phil.
Thank you for letting us know. Colleagues, any comments, or are you happy to... Ewan, and then back to Eleanor.
Sorry, it was like fastest finger first there, so apologies. No, just to further bit of information on the Pembrokeshire PSB. Obviously, it met last Friday, so obviously wouldn't have fit in with the paper. And as our chief executive rightly noted, both chair and vice chair roles are up for election again. But just picking up in terms of what Adriana said, in terms of that joint working, one of the key things which Pembrokeshire is looking at now as a result of a discussion last Friday is around the food sector, in terms of that impact, in terms of well-being around prevention, but also in terms of post kind of care, in terms of looking at sustainable well-being. And the Pembrokeshire Local Food Partnership, which already has about 110 members in terms of growers, suppliers locally, excluding your big players like Puffin Produce, etc., already working with Ceredigion and Carmarthenshire's local food partnerships. And also, I'm glad to say they're inputting into the dietetics team and colleagues within Howell Dda, looking at that healthy kind of eating programme for both people who are coming through our hospitals at the moment, but particularly around the prevention side as well, to kind of stop them coming through the door with diabetes and other kind of issues as well, presenting as that.
Thank you, Ewan. Very helpful.
Thank you, Ewan. And it is very joined up with our overall work on healthy weight as a health board with all the 3 PSBs, and it's been very helpful in that sense.
Great.
Thank
Yes,
you.
please, Eleanor.
Really useful paper. The point that Jill made about refreshing and having a look at how well it's working, is the population needs assessment for the whole of the 3 counties? And if it is, it would be useful to see it come back and look at it to make sure. We struggle sometimes working across all 3 areas, and if we are going to join up, and the RPB are going to join up the CALM service and the children's service, I'd welcome an opportunity to look again at the match against one against the other.
Yes, it is 3 counties, and a lot of work does actually go into producing that, so it really does produce some really good information that gives us a foundation for understanding that. And then similarly, the Market Stability Report looks at a whole range of commission services across a range of ages, and also helps us to identify specific areas where access to those services may be poor, or the range of services to support the needs of the particular groups that we have to consider under the Market Stability Report may be needing strengthened as well. So they're comprehensive reports that will again come through this board in due course. Thank you, Joe.
Thank you, Joe. Colleagues, are we happy to take assurance? Great, okay. Let's take assurance. And then any other business? Any items for other business? Can I raise one item? It's both the Chief Executive and I have been approached by the Envis network, largely concerned over the Supreme Court's decision regarding the status of trans people. Obviously, their concern is what does that mean for the implications inside the organisation, and we're due to meet with them in the next couple of weeks. I'm just wondering, perhaps, what work has been undertaken in preparation for thinking about that within HR People Services.
Yes, there's much discussion, as you can imagine, around that. There is a working group with NHS Wales around that. We have had an initial briefing, and there is further guidance to be issued. So we have got a position statement that we have shared. And we're just in very difficult times in terms of what we need to be doing and how we need to be supporting our patients and our staff.
Yeah. Thank you, Lisa. I mean, it seems to me they're anxious and they're uncertain about what this means and the implications of it, and feeling diminished and undermined by the Supreme Court judgment. What we need to do is to find some way to provide them with reassurance in a difficult time. So we will think about how we respond when we meet with them. But your guidance would be invaluable. Great. Okay. Any other business? No. Dan.
Not other business. It was next on Flight report.
Great. Okay. I'm now going to take us to the Flight report, which hopefully everybody's had the opportunity to speak to. Donna's not with us at the moment.
I just want to say how really good it is, and have it noted on record that it was informative and easy to read, and sad to say, but I enjoyed reading it because you got so much information out of it, and we heard the voice of our users. So I'd like to thank them for that report.
Thank you very much, Anne. Colleagues, other thoughts or questions? Darren.
Just reflecting on Phil's comment earlier, and last year we did include it as part of our People and Communities Experience report, and I think we probably need to make sure that we do that in the next meeting so that we can take any learning from this within the organisation.
I think it's always very helpful, and it is insightful, notwithstanding the fact it's hard to get the detail. You're right, Anne, it's useful to have statements presented in this way. It's very helpful for us, and I think any correlation we can do between this undertaken by an independent external organisation and our own findings would help to reinforce some of the things we need to think about when we action plan for some improvement or change. Great. Okay. Let's accept the board. Great. And then the board annual work plan. This is a working document.
Yeah, we'll update it after today's conversation, chairs, and include all the deadlines and new requests that we've included today.
Great. Thank you very much, Joe. Date and time of next meeting. There's an extraordinary year-end meeting, which is the second, 2 o'clock on the 26th of June. And then our formal regular meeting will be 9:30 Thursday the 30th of July 2025. Okay, I'm going to formally close the meeting now, and if what we do is take just a short refreshment break, and then we can begin the in-committee meeting. Thank you.